You can see it.
Okay, so we're going to be talking, I'm starting with the neurological stuff first. Going to be kind of winging it today. I got through some of this stuff, but a lot of you guys know from already doing the reading that there was a lot I didn't get to, so we're going to see how this goes. All right, so there's a lot of neurological problems that a baby can have. The most common are going to be things like seizures, and that can be caused by a lot of different things, fevers, infections that mom had maybe during pregnancy that may have caused some sort of neurological damage to the brain. It could be caused by some structural or neurological damage that the baby is born with. Encephalopathy, that generally refers to a level of alertness. Okay, so the baby might have problems with feeding or difficulty with breathing, and that would be mostly due to a decreased level of consciousness. Intracranial hemorrhage, this is bleeding that can occur in different parts of the brain, and an intraventricular hemorrhage, which can occur mostly in premature babies. Congenital neurological defects, those are a group of disorders that are present at birth, and they're usually related to some sort of brain or spinal cord malformation. That could be something like a neurotube defect or hydrocephalus. Lack of oxygen at birth or during birth or immediately after birth. There's a couple other neurological conditions, periventricular leukomalacia. This has to do with the white matter in the brain, so that's affected. Hypotonia, the baby could have poor or low muscle tone, and that can due to different neurological muscular conditions. That can also affect the baby's ability to breathe and feed because all that requires use of muscle tone. And then metabolic disorders, these are due to different biochemical reactions that may or may not have happened in the brain. Some are reversible and some are not. In some cases, these conditions could be inherited from one or both parents if it has something to do with like the genetics or the brain structure. Other factors that could contribute are mom's health during the pregnancy, exposure to environmental toxins, premature birth, labor or delivery complications, genetic disorders, and infections. The neurological conditions can also be caused by improper growth of the brain itself or the spinal cord. That could affect the way the brain or the veins inside the brain, that blood flow, or the spinal cord being weak or flexible. Premature babies are more at risk for disorders, and metabolic disorders like PKU can also cause neurological problems, and those are tested for and sometimes detected at birth. During the birthing process itself, a lot of issues can lead to development of neurological disorders. Again, that would be things like lack of oxygen, infections that are passed from mom to the baby, physical injuries to the head, and then immune disorders, other medical conditions, viral or bacterial infections like meningitis or encephalitis, and head injuries. Complications can be from mild to severe. Some children are going to have lifelong disabilities, and others might just be slow to reach developmental milestones. Some may not reach certain developmental milestones. Early diagnosis and treatment is the best way to minimize the effects or the complications. So the neurological system itself consists of the central nervous system, the peripheral nervous system, the autonomic nervous system, and we have these complex and coordinated interactions that allow these three parts of the body to integrate. And they incorporate the physical, the intellectual, and emotional activities. And we have to, as a nurse, understand how each part works. in order for us to conduct an accurate neurological assessment. Integration of the parts of the nervous system allow for normal functioning of the body parts, and they incorporate both voluntary and involuntary movement. A person's perception of themselves, their environment, reactions and interactions within the environment, and adjustment to developmental and environmental changes are influenced by the proper integration and functioning of the nervous system. The brain and the spinal cord themselves make up the central nervous system. Development of these structures occurs in the first 3 to 4 weeks of gestation from the neural tube. The central nervous system is composed of the brain, all its components, the spinal cord. Structurally, it's contained within the skull and the vertebral column. Infection, trauma, teratogens, which are any environmental substance that can cause a physical defect to either the baby, the embryo, the fetus, or malnutrition during that period, can result in malformation in the brain or the spinal cord, and that can affect the way the central nervous system develops. At birth, the cranial bones are not well developed, and that increases the baby's risk for a fracture. The skull protects the brain. The anterior and posterior fontanelles are purposely separated at birth to allow for that brain to expand and grow. The posterior fontanelle closes between ages 4 and 8 weeks, and the anterior fontanelle between 12 and 18 months. So the cranium is going to be very soft, especially in that preterm infant. Pressure from the outside can change the shape and cause increased pressure in areas inside the brain and possible hemorrhage. The sutures and the fontanelles allow the skull to be a little bit more flexible, and that accommodates for brain growth that continues at the birth. It also helps, to move that head down through the birth canal during the birth process. Closure of those fontanelles too early or too late can indicate problems with the brain growth. So that's why we're always monitoring the size and the shape of those fontanelles. We're always looking at them, evaluating them in the newborn. We're measuring them for size, and we're measuring them to make sure that they're not bulging, because bulging would indicate too much pressure in the brain. If they were flat, that would be good. That's how we would want them to be flat. If they were sunken in, it could indicate not enough pressure or dehydration. The brain is highly vascular, so that increases the baby's risk for a hemorrhage. Premature infants are at even greater risk for these types of hemorrhages because their capillaries are much more fragile, and they can break and rupture much more easily, and that can sometimes cause intracranial bleeding. And that can cause a lot of controversy. Does anybody know why?
But the brain?
Because during the birthing process, a lot of these capillaries will rupture, especially if there's trauma during the birthing process. And sometimes trauma happens and it goes unrecognized, and these babies will die. And what'll happen is, sometimes you get these hot shot cops that, this baby comes in the hospital, and the doctor or, whoever's on call might make a wrong call. And they might think that this baby has shaken syndrome, because the changes in the brain for this preemie can also be the same as what you would see with shaken baby syndrome. So a lot of times they'll accuse parents of actually shaking their baby and killing it. And if you look on the autopsy reports or on the MRI reports, what you can see is the hemorrhaging and the bleeding. But a lot of times they'll attribute it to the shaking baby syndrome when there are clear-cut records that show that these baby had these hemorrhages before they even went home with mom and dad. But of course, if someone comes from a lower income family and the baby is taken to the hospital because of this type of a brain injury, and it could be 2 or 3 weeks out because it could be a slow bleed. Of course, one of the first things they start looking at, because it's a brain injury, is did mom or dad do some sort of injury to the baby? Um, so it's just something to consider if you are working in the pediatric population before you would want to jump to a decision about shaken baby syndrome. You would definitely want to go back and look at what the baby's birthing experience was. Was there any risk for these hemorrhages to have occurred, and how far out is the baby? Now, if the baby's 6 months out, then I wouldn't say that. But if the baby's a few weeks out, we have to give all consideration here. Somebody is going to go to jail for murder of a baby, they're going to go for a long time. What else? The spine is mobile. The cervical spine region is a high risk for cervical injuries because of that mobility. The head of the baby is going to be large when we compare it to the body, about a quarter of the body weight. In adult, it accounts for about an eighth. So the neck muscles are not well developed, and the head's heavy. So we have to protect the baby's head whenever we're holding it, because it's not able to control those muscles yet. These differences will lead to also an increased incident of head injury for the child for falls. The head is the fastest growing part of the body during infancy, and it will continue to grow until the baby or the child turns around 5. Neurological disorders are divided into several categories. These include things like structural disorders, seizure disorders, infectious disorders, trauma to the neurological system, blood flow disruption disorders, and chronic disorders. Because of the sensitivity of the development of the neurological system in the first few weeks, there's a potential for defects to occur. And those type of defects that you might see are neurotube defects, microcephaly, Chiari malformation, hydrocephalus, intracranial arteriovenous malformation, and craniosynostosis. Also, between 4 and 10% of children will experience at least one seizure in a lifetime. Epilepsy accounts for about 3% of those, and about half of those start during childhood. Seizure disorders that originate outside the brain are generally caused by things like high fever, infection, head trauma, hypoxia, some sort of toxin, or some sort of cardiac arrhythmia. And there's different types of seizure disorders. We have epilepsy, febrile seizures, and neonatal seizures. Infectious disorders of the neurological system include things like bacterial meningitis, aseptic meningitis, encephalitis, and Reye syndrome, however you want to call it. Trauma or injury is one of the leading causes of childhood morbidity and mortality in the United States. The child faces a higher risk of trauma because of the developing neurological system and neurological disorders with life-threatening and lasting effects. The trauma could include head trauma, non-accidental head trauma, birth injuries, and near-drowning events. Blood flow disruption disorders. These are cerebral vascular disorders. They don't occur that often in children, at least not as often as adults, but they can cause mortality and morbidity in children. Sometimes they'll develop long-time cognitive or motor impairments because of these. And the cerebral vascular disorders are usually not seen until after the first month of life. Periventricular and intraventricular hemorrhages are seen most often in preterm infants or in infants up to a month. And then there are some chronic disorders in children that would also necessitate care. So these children are going to need education. The parents will need education and support. And they might be things like headaches or breath holding. All right, so on page 13, 29 in your book, it talks about assessment. Okay, neurological assessment. When we're doing it, we want to go from the least invasive area to the most invasive. You should use toys or objects that the child is familiar with and try to incorporate some sort of play into it to get the child's cooperation. You would want to do a thorough past medical history, and this would include mom's pregnancy history, any family history, any history of current illness, such as when the symptoms started, how long they've progressed, and what sort of treatments you've already or the family's already incorporated. Past medical history should incur any sort of prematurity because the nervous system is complete but immature at birth. We would want to talk about any sort of difficult births, right? Because we'd be looking at any sort of potential head trauma during the birthing process, hypoxia, anything like that. And infections during the pregnancy. What kind of infections might the mom have that could spread to the baby? So this could be STDs or any other sort of infection that might be detrimental to the baby. Any falls? Did the child have any recent falls? And any other sort of recent head trauma? Okay. During the infant itself is born with all the nerve cells that they need for the brain, but the myelination is not complete. All right. And that's what covers and protects the nerves. So speed and accuracy of our nerve impulses will increase as the myelination increases. So as that continues to develop, so will the child's ability to for the body to control those nerve impulses, and that those nerve impulses really attribute to both fine and gross motor movement and coordination. It also grows or accelerates in the direction of cephalocaudal, and the infants are able to control the head and neck before they're able to control the trunk because of this. Immaturity of the central nervous system in the preterm infant will result in a delayed development of the motor skills. They may have difficulty coordinating their sucking movements, swallowing, and that could cause both feeding and growing issues. Also, it can lead to episodes of apnea in the preterm infant. Other causes are that birth trauma, okay, that inadequate blood supply to the brain, blood incompatibility. So we might see that like with the Rh negative factor. That's why we want to give that RhoGAM at those certain intervals. And really, you're giving that RhoGAM anytime the blood has the capacity to mix, mom and babies. And then if there's a hemorrhage, that could also eliminate blood flow to the child. Infections, we talked about a little bit. Any sort of infection that might be transferable from mom to baby. So a lot of times you might see this with STDs. PKU would be more of a disease, not a process. But if mom had something like PKU or something like that, the baby could definitely develop. That would be more of a hereditary factor, and that could also affect the brain, especially if we don't catch it right away. So that's why we test for PKU within the first 48 hours of the baby being born, so we can make sure that the baby is able to process that protein. If it can't, then we're going to have to put the baby on a special formula so that it doesn't damage the brain. And then other infectious diseases we might see are meningitis, encephalopathy, brain damages, toxins. Mom ingests toxins and it crosses over to the baby. Baby itself could have some sort of head trauma during birth or after the fact. And then the baby could have different metabolic disorders that it's born with: hypoglycemia, hypocalcemia, hyponatremia, so on and so forth. So we would want to look at a history, complete history, physical and neuro exam. Again, we're looking at birth, development history, any significant illnesses, injuries, family history, any history of febrile seizures, and a comprehensive neuro exam. When eliciting the history of the present illness, we're inquiring about nausea, vomiting, changes in the gait disturbance, loss of motor function, visual disturbances, any changes in the level of consciousness, any increase in irritability, altered muscle tone, and then we'd also be looking at delays in growth and development, or a possible ingestion or inhalation of some sort of toxic substance or chemical. Common lab tests that we're looking at. All right, lumbar. Well, first of all, these will give you an explanation, hopefully, of what is going on with the child. All right, so we might use these to diagnostically determine if something is neurologically wrong. And then you have to be, as the nurse, familiar with how the test is obtained, what it's used for, what would be normal versus abnormal. Is there any special requirements to prepare the child? Are there any special requirements as far as monitoring before or after, and those kind of things? All right, so lab tests would include things like the lumbar puncture, cerebral spinal fluid analysis, intracranial pressure measurements, EEG, head and neck radiography, ultrasounds, fluoroscopy, CT scans, MRIs, PET scans, and single photo emission CT scan. So these different tests are going to tell you different things, okay? The first one is the lumbar puncture, all right? And we're going to take that cerebral fluid from the subarachnoid space. We're using this to diagnose for hemorrhages, infection, some sort of obstruction in one of the in the flow of the brain. And also we can measure spinal fluid pressure here. So for this lumbar puncture, positioning for one is important. Okay, how would you want this child positioned? Who knows?
Like
Lying on their side.
you're laying on his side, like maybe in a like kind of like fetal position, or you can like lay them on their. They can sit on their bottom and then just kind of like be linked over, like as if you were getting epidural,
Okay,
almost.
I would call it a kneaded chest position. So you're
Okay.
basically tucking the chin into the chest and pulling the knees up, right? So they can be in a fetal position, or they can be sitting up on a parent's lap, like sideways, right? And you could kind of curve them into this position, because if they're little, the child might be scared. So you might have to have somebody hold them in order to do this right.
Yeah.
And you're going in between the subarachnoid spaces. So you're going in between the L3, L4, or L4 and L5. And we want to make sure we don't damage anything or hit anything in that space. All right. So when they go in that fetal position, what it does is it helps to separate, all right, those areas so that we have a nice subarachnoid space that we can go in there without trying to involve any damage. All right. It is painful. So they might give local anesthesia or sedation. If the child's really upset, they might do it under general anesthesia. But it is a painful procedure. Okay. So what you're going to do is you're going to help position the child and help the child to remain still. We do have to use strict asepsis. We're also going to help collect and transport. We're going to monitor the respiratory status levels in the changes in the level of consciousness, heart rate. We're going to give fluids after the procedure if there's no contraindication. After the procedure, you're going to keep the child flat for an hour. Now, sometimes we use something called EMLA cream for this, or it's like an anesthetic spray. You can spray it on the skin, and it will just help with the little puncture of the needle. And the thing with that spray is a lot of people don't know how to use it right. So they don't put it on far enough in advance. It does take a good 45 to 60 minutes for that spray to work. So if you are going to use that, make sure that you're allowing time for it to work. All right, intracranial pressure. We're also going to look at that. All right, and we use a device that is placed on the head, and it's going to measure the pressure intracranially. And this is used to, if the client has hydrocephalus, some sort of acute head trauma, brain tumors, they might have a ventricular catheter that allows for draining of the cerebral spinal fluid, and that would help with eliminating the pressure. So this allows assessment of pressure that's exerted by the blood, the brain, the cerebral spinal fluid, and any other space occupying fluid or mass. And it helps diagnose different conditions like traumatic brain injury, intracerebral hemorrhages, subaqueous hemorrhages, hydrocephalus, CNS infections, encephalopathy. So normal is usually between 5 and 15. And increase would be defined as anything 20 or higher. Not sure that they'll really ask you about that, but it's good to know. You do see questions about increased cranial pressure and what normal should be. The EEG, this is going to measure electrical activity of the brain. We usually use this to diagnose seizures or brain death. It also helps evaluate some tumors, hematomas, and intracranial hemorrhages. I didn't go over the monitoring for the ICP, and I am. I'm not going to go over for the EEG, but I do see a lot of questions on lumbar puncture, ICP, so I just want to make sure you thoroughly understand that. So these patients are usually monitored in the critical care world. We're monitoring for infection. We need to keep the head of the bed elevated between 15 and 30 degrees. You don't want it too high. That 15 to 30 degrees is going to help to drain without increasing the pressure too much. Generally, they'll have some sort of an alarm on, and these patients need stimulation around them reduced. And any interventions that could cause pain or stress, we need them reduced because they could result in an increase in the cranial pressure. And then we would also be teaching them things to avoid that might increase their risk for increased cranial pressure.
Recording in progress.
The head and neck radiography, this is going to help to determine if the baby has any skull or spinal fractures. It also would show the location if they had some sort of ventricular catheter to decrease that cerebral spinal fluid. It also would tell us about increased cranial pressure or any sort of skull defects. Ultrasound is mostly used to look for intracranial hemorrhages in the newborn and look at the size of the ventricles. Fluoroscopy can help look at the spine and determine any sort of instability during movement. And then we also use CT scans, MRIs, PET scans, and single photo emission CT scans. These CT scans are used to help with congenital abnormalities like neurotube defects, hemorrhage, tumors, etc. MRIs to assess for tumors, inflammation, congenital abnormalities like neurotube defects, and it will show normal versus abnormal brain tissue. The PET scan will give us information on how the brain's functional development is going. It can also help identify certain focal points for the seizure, and it can assess brain tumors and brain metabolism. And then the single photon emission CT is used to detect brain death. It can tell us about the presence of encephalitis. It can help us to focus in on epileptic type of seizures. It can let us look at metabolic activity, evaluate brain tumors, and assess the child for development of any disorders. The nurse is assisting with testing on a newborn suspected of having a neurotube defect. Which diagnostic tests would be used to confirm this condition?
MRI.
MRI?
Isn't that PET scan?
The MRI or CT.
Okay, MRI is correct. That would be used to confirm the neurotube defect as it provides information about the bony and soft structures. The lumbar puncture helps measure intracranial pressure and obtain central spinal fluid samples. EEG is used to diagnose seizures and brain death by measuring the electrical activity of the brain, and fluoroscopy helps us assess the cervical spine for instability during movement. Medications used to treat neurological defects. So we have antibiotics. These are generally going to be prescribed to prevent bacterial meningitis and shunt infections. They will help kill and prevent the growth of bacteria. The treatment has to begin immediately after the lumbar puncture for the blood cultures if they suspect meningitis. Gram stain cultures can be identified in cerebral spinal fluid just within a few hours after administration of the antibiotics. Evaluation includes a cerebral spinal fluid exam, a CBC with differential and platelet counts, blood cultures, glucose and BUN, and creatinine monitoring, evaluation of the clotting factors. Isolation of the child would be necessary within the first 24 hours of therapy to prevent spreading of the infection. Anticonvulsants help decrease hyperexcitability of the nerves. All right, and that's used to prevent the actual seizure by decreasing that hyperexcitability. Complications from seizures can include physical injury during the seizure, brain damage, and respiratory insufficiency or arrest. Can you mute, please? Whoever's doing that, thank you. How is it treated? Most children are treated with anticonvulsants.
112.
Preferably a single medication to minimize adverse effects. Children who continue to have seizures with single medication are treated with multiple anticonvulsants. Medication dosage adjustments are usually needed as the child grows. And then we monitor drug levels in most of these to prevent toxicity. Benzodiazepines, these are sedatives that help prevent or stop the seizure by slowing down the central nervous system and reducing the ability for electrical activity to occur. This is going to be your major treatment for status epilepticus. So most of the time they're using Valium for this. And we give it in the form of something. You guys please mute if you're somewhere where there's background noise.
Nadine, can you mute?
Thank you.
I just texted her.
Okay, so the benzodiazepines are going to come. I'm just going to mute everybody's mic. If I need you to talk, then you guys can talk. I'll try to unmute, or you can unmute yourself. Let me see if I can figure out how to do that. Okay. Analgesics we're using to block the pain, okay? And most of the time we're going to use minor analgesics for, you know, things like headaches and stuff like that. But that's used in response to the prostaglandins that are inhibited. So morphine will act on receptors of the brain to alter the perception of pain. And that might be used to treat more of a severe pain. It also might be used if the child has an increase in cranial pressure to try to help control it. Osmotic diuretics are also used for the increased cranial pressure, and they're going to pull the fluid back into the bloodstream and back into the extracellular area, okay, to try to decrease the pressure. And that's something that would have to be done slowly. It's usually done in the ICU because if we pull the fluid off too fast, it can damage the brain cells. And then steroids are used to suppress the inflammation and the immune response and help reduce the cerebral edema. All right, ventricular shunts. So these are usually put in for fluid, if there's a fluid problem in the brain and we need to remove it for some reason. Usually from cerebral spinal fluid, okay, because it is in the ventricular system. And so it's reabsorbed by the arachnoid and it can cause hydrocephalus, okay? And when the patient has hydrocephalus, there's two types. It can be non-communicating or non-obstructive or communicating. When it's obstructed, that means the flow of the cerebral spinal fluid is blocked in that ventricular system. And that's more common than the communicating hydrocephalus. Usually this is caused by meningitis, trauma, tumors, or something called Chiari malformation. All right, and one of the most common causes of obstructive or non-communicating hydrocephalus in children is called aqueductal stenosis, and this is caused from narrowing of the aqueduct of the sylvius, and this is an area of passage that occurs between the third and fourth ventricles of the brain, and the flow of the cerebral spinal fluid is blocked between the ventricles, and so we're not properly absorbing the cerebral spinal fluid as we should be. So they're going to put this surgical shunt in. It's called a ventriculoperitoneal shunt. All right. And it will have to be replaced as the child grows. All right. One of the problems with these shunts, okay, is that they can develop infections in them. So a lot of times you'll see these kids after they have the shunt in and the shunt starts to act up. So things that would alert you to that would be changes in the level of consciousness. It might decrease. or they might start to deteriorate in how they're performing in school, or when you're talking to them, they may not be able to respond as quickly. They might have complaints of headaches, vomiting, visual disturbances, other things like that. So you're going to look at them. You want to observe them. You want to palpate and percuss. So things that you're looking at are the size of the skull, the shape of it. Is it symmetrical? Is it asymmetrical? Any asymmetrical areas of the skull could indicate an issue. You're also looking at level of consciousness. How well are they functioning? Are their movements, their reflexes, are they within normal limit? Do you see any spasticity? All right. And these symptoms could vary by age, and they're usually due to the fact that cerebral spinal fluid is still building up. So in the infant, usually what you're going to see is an increase in the head circumference. But in the older child, you might see lack of development, changes in the personality. So in the infant, we're palpating those fontanelles, okay, and we would expect them to be bulging, and they won't, they'll feel tense or full. As we percuss the skull, a positive Massawin sign might be heard or noted, and this is when you hear like a sound, a cracking sound when you're percussing or looking at the head, and that could indicate some sort of separation of the sutures. So for these kids, we probably do a skull x-ray, a CT scan, an MRI, and again, we're looking at symptoms of hydrocephalus, or the causes of the hydrocephalus from the malfunction of that shunt. So two major complications associated with the shunt are going to be infection and malfunction. And again, this is due to a lot of times either just from the abnormal component being in the body, and the body's trying to fight against it because it recognizes the abnormal. Sometimes when we have hardware in the body, vegetation likes to grow on it and collect on it, and that will cause the infection. And then malfunction could be from the child growing and the shunt not being replaced in time. So what kind of signs and symptoms will we see for this shunt malfunction? Vomiting, drowsiness, headaches. Signs and symptoms of increased pressure. And those are going to be listed in your book on chart 38.1. All right, so if you see increased cranial pressure or vomiting, drowsiness, and headache. The infection can occur anytime. It's most common about 1 to 2 months after it's put in. And it's going to be treated with IV antibiotics. If it continues, then they'll remove the shunt and they'll try to put an external device in place. Rapid drainage of cerebral spinal fluid can occur if the child sits up without the external vice system being clamped, and that would decrease the ICP, and it would cause the child to have an extreme headache, collapse of the ventricle, and development of a subdural hematoma and neurological deterioration. So you have to make sure, if you do have the external ventricular device system on, that it is clamped appropriately when the child goes to sit up. All right, a new shunt is going to be placed after the infection has gone away or is cured. Okay, and then we may have to give intrathecal antibiotics. Okay, and we'll continue to monitor for the infection. Okay, and then after the shunt is placed, the new shunt is in place. We're still monitoring for infections, any signs of leaking cerebral spinal fluid. For malfunction of the shunt, this can occur due to kinking, clogging, or separation of the tubing. Blockage is the most common complication. A shunt that's placed within the last year is at the highest risk for malfunction. And then early recognition of the operations are essential to prevent that neurological function. Family support, you're going to need a lot of family support for these children that have hydrocephalus. We have to be able to recognize it early and try to prevent neurological complications or damage. For the families, it's going to be a strain because of frequent hospitalizations, surgeries. It can put a strain on their finances. I'm just looking for some of this other stuff that's here because I didn't get to these notes yet. So let's see if I can find it in your book. So you might see hyperventilation during the process of this, okay? And the body, this is what the body does if it feels like it has too much CO2 on board. So it's going to cause the patient to hyperventilate as part of the buffer system. So it's trying to compensate for that increased cranial pressure, okay? When it happens, it will cause vasoconstriction in the body, and it will help the body to decrease the intracranial pressure. So we want to make sure that with the patient, if they're having any hypoxia, that we're adequately oxygenating them. All right, because if you don't and you cause them to go into the hyperventilation, that itself could increase the cranial pressure and make the patient worse. So you need to monitor the ABGs. You need to monitor for signs and symptoms of increased cranial pressure. PT and OT, we're going to involve them to help improve motor function in these children. External catheters, again, if the internal catheter is blocked or not working, then we may have to put the external catheter on until the cerebral spinal fluid is sterile and the shunt can be replaced. The ventricular tap, this is going to help reduce the accumulation of the cerebral spinal fluid and decrease the pressure. For these patients, we're monitoring the level of consciousness and neurological status. The vagal nerve stimulator, this is usually used for seizure management. Are you guys familiar with them?
What the
VNS?
no.
So VNS are implanted surgically, and what happens is there's a when they put it in there, there's a little switch in there, and it switches back and forth to stimulate the vagus nerve during a seizure to try to stop the seizure and try to decrease the symptoms of the seizure. So they surgically implant it. The old ones and the ones for like the Medicare patients, they come with a magnet. So when the patient has a seizure, you can take the magnet and you swipe it across the chest up where the magnet, where the VNS is implanted, and it will close the switch or make the switch connect so that it decreases the seizure activity. If the child's lucky and they have one of the newer ones, it's an automatic one. The new ones actually can kick in automatically, so no one has to swipe it, and they actually can recognize the aura. You guys know what the aura is? So
Yeah.
If
Yes.
someone has a seizure, usually they'll have what we call an aura. Well, they'll have certain sensations. They'll see certain things. They'll have a certain smell,
Now, yeah.
taste in their mouth. So a lot of times, if they're not developmentally delayed or they don't have some other cognitive issue, the clients can say, hey, nurse, I feel like a seizure's coming on, or hey, staff, I feel like a seizure's coming on, and they could go ahead and swipe that vagus nerve and try to prevent that seizure. But the autonomic ones or the automatic ones, they now can actually feel that aura on the patient. They can sense it and it kicks in. They're pretty cool. And then the ketogenic diet. So this might be offered to help control or reduce seizures, especially if the child has like epilepsy and they have dangerous seizures. So this would involve intake of fats, adequate protein, low carbs, and a ketosis state and a mild state of dehydration. And I see that they don't have it here in your book, but they are using medical marijuana now to treat seizures. New Jersey has already incorporated some of the medications that they're using. Colorado is big on it. They have a company that makes recreational marijuana, but they take the profits from that. There's 5 brothers, and they make a product. I forget what it's called. It's named after a kid that has seizures, and the kids don't smoke it. You know, they give it to them. It has a very low THC content, but it has to have a small amount of THC in order for it to activate like the cannabinoids in it. And I saw this whole special on it with the medical director of the United States. And they were showing how they were able to reduce this. One kid was having like 34 seizures a day. And now the kid doesn't even have that many in a month or in a 6-month period. So they have like one every 6 months now with using this product. So, you know, a lot of good stuff coming out there now with the seizures. I think that if they could use maybe the medicinal cannabis and use the swiper, the VNS, the automatic one, they might be able to totally eliminate seizures in some of these kids. The problem with seizures is what's happening in the body when that seizure activity occurs.
Brain is not getting enough oxygen
Why though?
because of the stimulation that's happening, like the overfiring of the electricals.
So we have electrical activity going on in the heart, okay, because electrical activity happens in the brain and the heart during the seizure process. And so it disrupts the normal flow of blood and oxygen. So yes, the patient could have a massive heart attack or something else during this time. So it's really important to oxygenate your patients during a seizure if you can get the oxygen on them. You probably would want to use like a non-rebreather in this state. All right, other factors, risk factors for neurological disorder are being born premature, mom's use of drug and alcohol during pregnancy, infections during pregnancy, any medications. So we're always looking at what medications cross that barrier. All right, and then the baby's lack of nutrition in utero. So we're addressing this by trying to get these young women that are in the ages where they might become pregnant, right? We want to get them before they get pregnant. So we have to address this with like these high school girls, Planned Parenthood, all those places. We're talking to them about what type of supplements, what type of prenatal care they need before they get pregnant. And it's not during just during pregnancy, but if you're at the age where you want to become pregnant, you know, your body should be in good shape. It should be prepared. And so we want to make sure that, you know, mom's been taking enough folic acid and some of those other supplements that she needs to prevent these complications. So there's a bunch of different types of seizures. Again, I gotta find this in your book because you get to these notes, but we'll find it. Let's see. I got to as much as I could get to last night, and then I fell asleep. I was like, I couldn't do it anymore. Not that I'm not familiar with most of this stuff, because I am, but I want to try to give it to you the way it comes from your author, because that's what you're going to be tested on. Okay, let's try infantile. I don't even see this infantile spasms in your book. Okay, let's see. So generalized seizures include absence seizures, tonic-clonic seizures, myoclonic seizures, atonic seizures. And then unknown are epileptic spasms, tonic-clonic, focal to bilateral tonic-clonic seizures. So we have a lot of different types of seizures, and the classification and the type of seizure helps tell us how to manage it and control it. The new classification is based on 3 key elements. Where did the seizure begin in the brain? So if it happened on one side, it's considered a focal seizure. If it's on both sides, it's considered a generalized seizure. And seizures are all assumed to affect consciousness in some way or form. And then the third feature is whether or not the seizure involves movements such as stiffening, jerking, or automatisms. So we'll see this when you do charts, when you do paperwork for the seizures. What you'll see is on it, it'll ask you, like, what kind of symptoms did the person present with? Did they urinate on themselves? What happened to them during the seizure? Did they lose control in any sort of way? And so on and so forth like that. So basically what the people are looking at is ways to prevent the things that are happening to that patient during the seizure, to prevent complications after the fact. So infantile spasm, this is a seizure disorder in the baby that'll make the muscles and arms and legs stiff, and it causes the baby's head to bend forward. The baby will look like they're having some sort of a startling effect, and it might cause them to have a slow development and loss of skills, like babbling or crawling or things along that line. The absence seizure, that's going to cause you to blank out or stare out for a few seconds. They're sometimes called petit mal seizures, and they're the most common in children. They usually don't cause long-term problems, but they can be set off by a period of hyperventilation in the child. The tonic-clonic seizure, it's what we call a two-phase seizure. So it has two phases. In the tonic phase, the body will become rigid, and in the clonic phase, it'll be uncontrolled jerking. These usually don't have an aura, but after the fact, they'll have headache, confusion, they may be sleepy, and they can last for a few seconds or several minutes. They're also sometimes referred to as a grand mal seizure.
So the book says that it's associated with an aura. I just want to make sure because there might be a question right here on 1344 at the end of this chart. And I don't know if I'm in the same place,
Let me
but
look at it.
yeah, it says generalized onset motor, and then it says the tonic-clonic, formerly grand mal.
What page are you on?
I'm on 1344 and it like chart at the bottom. I'm just following as you read, and when you said it was not usually associated with the aura, it says it that it is. So I'm just making sure. It's 1344. Is that table 38.2?
Why is mine going down? 38.2, right?
Yes, that's the table. And then down at the bottom.
On the tonic-clonic, right?
Yes. So the formerly grand mal, that part. And then when it comes down to characteristics,
Associated with an aura. Okay.
and I'm sorry. I just wanted to make, because I feel like if that's the
Listen, we're gonna go with what the book says.
okay.
Okay. I'm reading from some other notes that I had, so this may have changed.
Got it. Okay,
I know it
understood.
could be from an older thing. Okay, so let's go with associated with the aura then. We're gonna put that in there because I don't want you guys to get this wrong. All right, so you're gonna have a loss of consciousness. All right, and again, the entire body is gonna experience back and forth between those jerking movements. Thank you for bringing that to my attention. All right, so myoclonic, this is going to involve the cortex of the brain, and it can happen with other seizures. With this, you're going to see that brief, massive muscle jerks that can involve the whole body or one part, and the patient may or may not lose consciousness. Atonic, where we have the loss of muscle tone. Okay, a lot of times you'll just see the head drop. And usually they call these drop. We call these drop seizures. So a lot of times the head will drop and then the whole body will drop down. All right. These happen in patients called Lennox-Gastaut syndrome. These patients a lot of times don't respond well to some of the seizure meds that are out there. So these are some of the candidates that I'm talking about that they might use the cannabis for. Okay, simple partial. These are seizures that may occur in one part of the brain, and symptoms are going to depend on where they occur at. It can be clonic or tonic movements involving the upper extremities. It could be sensory signs like numbness, tingling, changes in the hearing and vision. And these patients will look like they see hallucinations. They'll give these blank stares in the air. Also changes they'll have in blood pressure, heart rhythm, bowel function. Again, these patients can remain conscious during the seizure, and they may vocalize during the seizure. For these patients, typically they don't have that post-ictal state. So the postictal state, if you're not familiar with it, usually they're sleepy and snoring in that state, or sometimes they'll make funny breath sounds during that state. With a complete partial seizure, this might begin with a focal seizure, meaning on one side of the brain, right? And then without impaired consciousness, and then it can go on to a full blown seizure. They may or may not have an aura. Consciousness will be impaired. They can have purposeful movements, especially in kids or infants. And then things like lip smacking, chewing, swallowing, excessive salivation can occur. So if you guys haven't heard that, you'll hear it. Like you'll hear the sound that they'll be making. Okay. And then also another thing that you'll see them do is pick and pull at their clothes. So it looks like they're trying to pick off little pieces of lint, and they'll constantly pick at stuff. And those, they say, are the hardest to control. And then status epilepticus, usually this is when the seizure occurs for more than 5 minutes. It is considered a neurological emergency, and it can be life-threatening. So for that, you're going to give usually diazepam. We give it in the form of something called Diastat, and it's usually given rectally. But most of the time, you're calling 911 for these patients, especially if the patient is developmentally delayed. Drugs, you guys should be familiar with the drugs that they use for seizures. Okay, I would definitely know my Dilantin, Depakote, phenobarbital, carbamazepine, gabapentin, topiramate, lamotrigine, levetiracetam. Those are the most common drugs that are used for these patients. And a lot of them can cause other issues in the body, like the Dilantin. For one, that has to be shaken all the time because it can become toxic. It also has therapeutic levels, and so they're going to expect you to know those. The Depakote they ask about a lot. Depakote can be given in a pill, it can be given in a syrup, and it can be given in something called Depakote sprinkles. The Depakote sprinkles are actually capsules that you can open up and you can sprinkle it on the food. So a lot of times these clients will prefer those because they don't really have a taste to them. The carbamazepine, you also are going to want to know the levels for that because they do test you on the levels for that. All right, and expect you to know it, and side effects for those drugs as well. For the phenytoin, it's usually the gingival hyperplasia, monitoring the vitamin D levels, calcium levels. It can cause osteoporosis if it's used long term, and I believe it can cause blood dyscrasias. For the Tegretol or the carbamazepine, you have to be careful if you give that with other anticonvulsants. You have to monitor the therapeutic levels in that. You also would want to monitor your folate and your vitamin B levels with that. So for seizures, kind of things mostly you're going to do is the EEG, because that's going to really measure the seizure itself, where and when it's happening in the brain. The video EEGs can also help to reel it in a little bit closer. They might do a CT scan or an MRI looking for causes of the seizure, like some sort of brain abnormality, some sort of bleed, some sort of tumor. And then they might do a lumbar puncture if they thought that the seizure was somehow related to an infection like encephalitis or something along that lines. Seizures are scary for the parents, okay? So you're going to want to teach them about those types of seizures and what to expect. Just going to go back to that other slide for a minute. Did we go over those? Okay. All right, so because of that sensitivity of the neurological system during the first through few weeks of life, we have to look for structural defects. And those structural defects are things like neurotube defects, microcephaly, Chiari formation, hydrocephalus, intracranial arteriovenous formation, and craniosynostosis. The neurotube defects are the most common. All right, and this includes defects of the brain, of the spine, and things like spina bifida, myelomeningocele, and encephalopathy, and encephalocele. The neurotube is going to close around the 3rd to 4th week when the baby is still inside of mom, and the cause of the defects is not exactly known. But they do know that there are some contributing factors such as malnutrition, chemicals, and genetics. Folic acid is the one thing that they do look at. They do know that if mom takes in an appropriate amount of folic acid, that it can decrease the risk for the neurotube defect by up to 50%. So we would want anybody that is of childbearing age, okay, meaning if they have the risk to become pregnant, even if they're not trying, because you don't have to try to get pregnant, right? They take 400 micrograms of folic acid daily, all right? And then if they have a history of neurotube defect in the past, then we would want them to take a higher dose. Also, we would screen them for something called A-fetoprotein and do an ultrasound to look for any other risk factors. Encephalopathy, this is a defect in the brain where part of the brain is missing. One of my foster kids actually just had a baby born like this, and the whole top of the skull was missing. And it's tough for these parents because, you know, in the beginning, it kind of seems like the baby might survive, but these babies don't really have a very good chance of survival. The cephalic or the upper end of the neurotube doesn't close like it's supposed to. And so the baby's born without a forebrain and a cerebrum. And then their remaining brain tissue are actually exposed. And so you could actually look in, they kept like a stocking cap sort of thing on top of the baby's head. But if you remove that, you could actually look into the baby's head and see the brain. She lived to be, you know, about 2 weeks old. These babies will have a distinct appearance. So they'll have that large defect in the skull. Moms might have a difficult labor because of the brain. The malformation of the head does not allow it to engage properly into the cervix. Most of these babies are going to be born stillborn, and if not, they die within several days to weeks of birth. There are a few cases where the infant has lived several months, and I actually saw a couple because I was reviewing this when she told me about the baby, and I actually saw a couple kids that lived to be a few years old. Probably multiple surgeries in order for that to happen. But usually the baby is going to be blind, deaf, unconscious, and not able to feel pain. So, you know, they'll give these babies sucrose water to probably help make them feel comfortable. They are born without a brain stem, or they may be, okay? And so there's no possibility of gaining consciousness because they don't have a cerebrum. And then their automatic reflexes like respiration, reactions to sound and touch, and ability to suck could still be present, as we saw in that baby. Like some of those instincts were still there. Prognosis poor. Okay, so you're going to be going through the grieving process with this parent. Okay, preparing them for that part. If you look on page 1351, okay, this is what the babies really look like. All right, so with the cap, that we did encourage like bonding with the baby and everything like that, and holding the baby and all that for the mom, okay, because the baby may live for a few days, so you want mom to do that if she can. And so by putting this cap on the baby's head, it allows them to be able to hold the baby, be able to touch the baby, and be able to bond the baby with the baby. The encephalocele, this is where the brain and the meninges are damaged or protruding through the skull. And that's because, again, the anterior portion of the neurotube doesn't close. And the size and involvement depends on the extent of the complications and what type of defects are also present. Often you'll see not only the head or the cranium, but also facial abnormalities. You'll also see hydrocephalus, microcephaly, sometimes spastic quadriplegia, ataxia, and visual problems, as well as developmental delay. These children will have mental and growth retardation and probably seizures. And most children that are affected can display, or some children that are affected can display a normal level of intelligence. These children will require surgical repair, replacement of the tissues in the skull, and removal of the sac, possible shunt placement to correct the hydrocephalus, and then repair of any craniofacial abnormalities. So after delivery, they're going to have this visible external sac that protrudes from the skull, most common around the occipital area, but it could be anywhere. The lesion is usually covered by skin, but it could be open. And the sac will remain in, we hope that the sac remains intact, and then we're checking that neurological status carefully. Before surgery, the baby will be evaluated to look for any brain tissue involvement or any other anomalies. Diagnostic for this patient is going to be CAT scan, MRI, and ultrasound. So this baby, you're going to take care of similar to how you would take care of one with meningocele, which is basically we're protecting that sac to prevent it from rupturing. We're preventing that infection. We're providing adequate nutrition and hydration. Also, we're monitoring them for increased cranial pressure and head circumference. And we may have to position them in ways to protect that sac. The microcephaly, this is the where the head circumference is off, okay? And it's below. It's lower than what it should be for the age or the sex of the infant. It can be congenital. It can be acquired in the first few years of life. And it usually results in intellectual disability because the brain is, the tissues of the brain is not functioning appropriately. It can be caused by abnormal development during gestation and some uterine infections like rubella, toxoplasmosis, and cytomegalovirus. It also can be caused by some sort of chromosome abnormality, severe malnutrition, perinatal infection, or lack of oxygen in early infancy. So at birth, they'll have either a normal or a reduced head size. And the head growth, remember, that is going to grow very fast, okay, on the child. But in these children, they're not going to have that growth. The face will grow normally, but not the head. So they'll have a small head, a large face, a wrinkled scalp. And as they grow older, it'll look more pronounced because, you know, the rest of the body is going to continue to grow. So they might have functions with problems with motor function, problems with speech, and intellectual delay. The Chiari malformation, this is classified into a couple of groups based on how the anomaly occurs. Most common type are 1 and 2. 1 is not usually associated with hydrocephalus, and it's more benign. It's usually caused by cerebellar tonsils displacing the upper cervical canal. Type 2, also called Arnold Chiari, is the most common, and it's usually associated with the hydrocephalus, the myelomeningocele, and it results from a deformity in the cerebellum, the medulla oblongata, and the fourth ventricle, causing the cervical canal to be displaced, and that causes obstruction of the cerebral spinal fluid and then the hydrocephalus. Prognosis is going to depend on how bad the defect is, or how far it extends into the brain, or how far it affects the body. And then management would include, for type 2 Chiari formation, some sort of surgical decompression. Hydrocephalus usually is caused by some other underlying condition in the brain. It's often seen in patients that have an imbalance in the cerebral spinal fluid. So they're either not producing enough or they're not reabsorbing enough. And so the cerebral spinal fluid will accumulate in those ventricles and cause them to enlarge and increase the intracranial pressure. It can be congenital or acquired. If it's congenital, then it's usually present at birth, and it's due to some sort of genetic disposition or environmental influence while the baby is developing. Other issues that could cause the congenital hydrocephalus are abnormal intrauterine development, like myelomeningocele and other intrauterine infections. Acquired hydrocephalus will develop at the time of birth or after birth, and that can happen at any age, and it can be caused by injury or disease. It can also happen from either intentional or non-intentional trauma, some sort of hemorrhage in the brain or in the ventricles, in those premature infants, some sort of brain tumor, infections like meningitis, or those Chiari malformations. So for the child with hydrocephalus, their outcome or their prognosis will depend on why they have it or what the cause of it is, whether or not they have brain damage, and whether or not they were able to do some sort of prevention, early recognition, and treatment. Because of this increased pressure in the brain, they're also at risk for developmental disabilities, problems with their vision, their memory, and their intelligence. And they'll need long-term follow-up. For the intracranial arteriovenous malformation, this is a congenital disorder, and it's caused by abnormal development of the blood vessels in the brainstem, or the spinal cord. It can cause hemorrhage, neurological deficits, and even death. and some cases never cause any problems. So they're going to be aggressive with these children, and they may do things like surgery, endovascular embolization to close off the vessels, and other types of therapeutic treatment, all right, like brain surgery. And then the craniosynostosis, this is where we have premature closure of the cranial sutures. Usually the sutures don't happen until late in childhood. If they do happen prematurely, they can inhibit the brain growth. They can distort the way the head looks. All right. And only one suture may be fused. Okay. Well, with that, then we don't see much in the way of neurological impairment. But if two or more are, then we may see more neurological complications and increased cranial pressure. Causes unknown. They do suspect that genetic disorders like Carpenter syndrome, APERT, Cruzon, or Pfeiffer can maybe possibly be connected with it. Prognosis is good for most of these babies, and they expect their brain development to be normal once they do the corrections. All right, so infectious disorders include things like bacterial meningitis, aseptic meningitis, encephalitis, and Rey syndrome. Bacterial meningitis, this is infection of the meninges, and it's serious in kids. It can cause brain damage, nerve damage, deafness, stroke, and even death. It's going to affect the lining that is around the brain and the spinal cord. It has to be treated quickly. All right, so it usually results from something called Haemophilus influenza type B, the most common cause of meningitis in children. And can you mute, please?
They are snoring. They cannot hear you.
I guess.
Oh my God.
Let me go back. I'm going to put all on mute again. Then you guys that want to come off can.
I think it's Farah.
She works
She works,
overnight. She be tired.
Yeah.
yeah, she works night. Yep.
Okay. You think it's her?
Yes.
Yeah, that's her. I texted her.
She's not going to answer if she's snoring. Okay. So I muted her, I think. Okay. Okay. So we want to have the babies get that HIV vaccine to reduce the risk for the meningitis. All right. So with this, we're going to see inflammation, swelling, tissue damage to the brain. It's a medical emergency. All right. So deterioration can happen in less than 24 hours, causing neurological damage and death. We're going to give IV antibiotics. We're going to get blood cultures. We're going to do the lumbar puncture and get those cultures. Okay. If it's bacterial meningitis, then they'll get antibiotics. If it's viral, they won't. And then the treatment will depend on what the actual culture finds and what the sensitivity is to it. Steroids can also be ordered to help reduce the inflammatory process. Again, you're looking for signs and symptoms of increased cranial pressure, sudden onset of symptoms, respiratory illness or sore throat happening right before this. The patient's probably going to have fever, chills, headache, vomiting, stiff neck, muscle rigidity, seizures. In infants, symptoms can be more atypical. So for these patients, you're going to see things like poor sucking and feeding, a weak cry, lethargy, vomiting. They may hyperextend into what we call an epistotonic position, where the head and neck are hyperextended to relieve comfort. So you want to watch the infant for that. Okay, a bulging fontanelle may be present, and that's usually a late sign. The infant may be consolable when lying still as opposed to being held. And then we're looking for the Koenig and Brudzinski signs. These can indicate irritation of the meninges. We're also looking at the child for a rash, petechiae, any sort of vesicular or macular rash. If they do have this eruption of the petechiae or the purplish rash, this can be related to something called meningococcosemia, and it requires immediate medical attention. So lab tests for the bacterial meningitis would be the lumbar puncture. We're looking at that cerebral spinal fluid, and it would have white blood cells increased in it, protein and low glucose, all right, because the bacteria like to eat that glucose. CBCs, blood, urine, and nasopharyngeal cultures, and they're looking for the source of infection and ruling out sepsis. Antibiotics, proper ventilization. We have to reduce the inflammatory response and prevent any injury to the brain. So we want to reduce that intracranial pressure. We would want to prevent seizures. We would want to make sure that the fluid volume is okay, that we don't have any changes in the level of consciousness. We're going to have to isolate these patients, okay, in addition to standard precautions. Those with bacterial meningitis would be placed on droplet isolation until 24 hours of antibiotics have been received to prevent transmission to other people. So Koenig sign is going to be in figure 3814 in your book. This is tested by flexing the legs at the knee and the hip and then extending that knee. A positive report of pain along the vertebral column or the inability to extend the knee is a positive sign and indicates irritation of the meninges. The Brudzinski sign is tested by having the child lie supine with the neck flexed. A positive sign occurs if resistance or pain is met. The child also passively flexes the hip and knees in reaction, indicating a meningeal irritation. So you're going to want to reduce that fever, okay? And you already know, we can do this with fluids. We can use cooling packs, fans, cooling blankets, remove clothing, tepid baths. Those are all things that we would do, okay? We wouldn't want to do anything that would cause shivering because that would be counterproductive. So for the vaccination for meningitis, it's routine for all kids 11 to 12 with the booster at 16. I think there's another one. Wait a minute. Vaccines, the HIV starts at 2 months. All right, so all children should be immunized to continue to reduce the risk for the bacterial meningitis. So that starts at 2 months. The pneumonia vaccine is also routine for all children starting at 2 months. Then meningococcal vaccination is routine for all kids 11 to 12 with the booster at 16. And adolescents at 16 to 18 can be vaccinated with B meningococcal vaccines if they're part of a specific risk group. All right, aseptic meningitis, this is the most common type. Most kids affected are under the age of 5. If they can identify the factor, it's usually related to a virus. Enteroviruses like echovirus, Coxsackie virus account for the majority. Other less common causes include mumps, herpes, measles, influenza, vector-borne like the Zika, and West Nile virus, and lymphocytic choriomeningitis. If the cause is viral, most likely antiviral agents will be started. Okay, so they might start them on antibiotics until they identify whether it's bacterial or not. Usually once they identify that it's no longer bacteria, then they'll switch over to the antivirals. Usually this will last about 3 to 10 days. Common signs are fever, headache, poor feeding, nausea, vomiting, neck pain, positive Kernig and Brzezinski signs. Onset could be abrupt or gradual. Assessment findings will be similar to that of bacterial meningitis, but usually the child is not as ill. So we're going to use measures to reduce pain and fever. And if there's no neurological compromise, then we might send the patient home as long as they can tolerate oral. Encephalitis, this is when the brain is inflamed, and also the meninges. It can be caused by protozoan, bacterial, fungal, or viral invasions. Usually the viral illness and autoimmune disorder is the most common cause in children. So we look at common causes in children as being those of enteroviruses such as polio, Coxsackie, herpes virus 1 and 2, or vector-borne. It usually will go away after a few days. If it doesn't, it could become complicated and cause severe neurological damage. Prognosis will depend on how old the child is and what the organism is that caused it. We do have to get these children quick diagnosis and treatment. They're generally going to be hospitalized, and we're going to manage them by focusing on cerebral perfusion, hydration, nutrition, and preventing injuries. These patients might present with fever, flu-like symptoms, altered level of consciousness, seizures, weakness. So you're looking at things for recent travel, okay? Because if you think it's vector-borne or from a tick or something along that way, then we need to know if they've traveled, or mosquito, if they traveled, have they hiked, have they camped, do they have any association with any animals? We're doing a neuro exam, all right? And we're looking for changes in senses and focal neurologically. We do a lumbar puncture and a cerebral spinal fluid analysis, looking at leukocyte count and elevated protein and glucose levels. Other diagnostic testing are going to be MRIs, CAT scans, or EEGs to try to identify any changes in the brain and help us diagnose. So antiviral therapy, especially if it's caused by the herpes virus, teach about ways to prevent it. Encephalitis can come from complications of certain childhood diseases like measles, mumps, or chickenpox. Children have to keep up to date on their immunizations to prevent these things. Other things that might be effective or would be like rabies shots. If the child got bit, by a dog or something, we want to make sure they get that series. Post-exposure vaccines for anybody that was bitten by a suspected or rabid animal. So I would say if my child got bit by a dog and that person can't support the rabies shots, if they don't have evidence, then I would want to get them treated for this. Preventative measures, okay, to prevent mosquito and tick bites. So, repellents that have the DEET, but you have to be careful with these in kids under 12. Okay, they do have some natural products out there on the market that are supposed to be effective, that you can recommend or look into. Having the children cover themselves with clothing if they're going into these types of wooded environments, and light colored clothing. Controlling mosquito populations. So teach the parents that they don't want to have water like standing around in their backyard. So if they have like wheelbarrows and buckets and stuff out there, they would want to flip them upside down. The water gets into the buckets and stays in there. The mosquitoes will breed in that standing water. Using insect traps and other measures like insecticides to reduce the risk. Rye syndrome, this is rare, usually affects kids under 15 and those that are recovering from a viral illness. Exact cause is not known, but there is an association with the use of aspirin or aspirin-containing products that are used to treat a viral infection. It will cause swelling of the brain, liver failure, and death within a few hours if not treated. So we're not using aspirin, you know, in kids under a certain age, right, to prevent this. And then you would want to know what the signs and symptoms are. So signs and symptoms are change in mental status, lethargy, severe continuous vomiting, confusion, hyperreflexia. Most of the time, these children will have a history of a viral illness like chickenpox, croup, or flu, or even an upper respiratory infection. And then they've taken this aspirin or this salicylate-containing product within 3 weeks of the virus or the illness. What else do we have to worry about besides aspirin in these kids? What else do we want to consider not giving them?
Rye syndrome.
Yes, for Rye syndrome, for prevention. What else will we not give them besides aspirin?
Like
Alka-Seltzer and Pepto-Bismol.
Alka-Seltzer, yeah, Pepto-Bismol.
Okay, good. Because those drugs all have the same product in it. So you have to be aware of that, because sometimes if they have the flu or whatever, you might want to give them something for that vomiting. And you don't want to give them anything that has the aspirin in it. So it's not just the aspirin, it's anything that has the salicylate product in it. Diagnostic tests would be a liver function test and an ammonia level test. So central nervous system has a balance of fluid, all right, with that cerebral spinal fluid that bathes the brain and the spinal cord, and the specific pressure called intracranial pressure. The problem is the brain is super small. So if other fluid comes in there that doesn't belong in there, there's nowhere for it to go. So it's going to cause this increase in pressure, and it's going to start to push things around in there. The elevated increased pressure is a sign of a neurological disorder. So we can have other things that happen to us that could cause this. One is trauma. Okay, so trauma is a leading cause of childhood death, okay, in the United States. And often the trauma itself can cause a neurological problem or a neurological disorder, and it will last for a long time. So for children, common causes of head trauma are falls, motor vehicle accidents, pedestrian, bicycle accidents, and child abuse. Because their head is larger than the body, they have this higher center of gravity. And so when they fall or when they're involved in some sort of jerky motion, the head is going to flop around and be injured first. They're also at risk for injury related to psychosocial factors such as the high activity level, curiosity, incomplete motor development, and lack of judgment skills or knowledge. Head trauma is a broad term. It's often described as TBI, traumatic brain injury, when we have this trauma that results in a disruption of the normal function of the brain. Not all head trauma results in traumatic brain injury, all right? But it is a serious complication that can cause an immediate threat to the child's life, and complications that can lead to lifelong impairment of the individual's cognitive and psychosocial functioning. So some common head injuries that we see in patients are skull fractures, linear skull fractures, depressed skull fractures, compound fractures, basal skull fractures, contusions, hematomas. So a lot of issues can happen. So what kind of signs are you going to see early versus late? Okay, with this increased cranial pressure that can be caused by, one of these types of head injuries. So headache, vomiting, visual changes. Those are the ones you see a lot of. Sunset eyes, those are in the baby, and it's very specific. Like when you look at the eyes, you can only see half of it. They look really weird. Like it looks like the eye is cut off at the pupil and then it goes up towards the head. The bulging fontanelle and the increasing pressure. Then late, we'll see decreased level of consciousness, decrease in the responses in the body, bradycardia, irregular respirations, Cheney-Stokes, decerebrate and decorticate postures, fixed and dilated pupils. So this is going to be your triad, your Beck's triad. All right, the bradycardia, the irregular respirations, and the change in the blood pressure. All right, hydrocephalus, we talked about this a little bit, so we'll just go through this again. All right, we're going to see an imbalance in the production and the reabsorption of that cerebral spinal fluid. You're going to see signs of the increased cranial pressure. So for babies, we know that's going to be, you're going to be looking at that head circumference, right? What else are we going to see as far as the signs and symptoms? Hello? Unmute.
Irritability.
What else are we going to see?
Gonna be
Signs and
irritable.
symptoms of that increased cranial pressure.
Bulging frontal
Okay, bulging fontanelles.
and sunset eyes, you said.
Okay, what else?
Decreased heart rate and respiration.
Okay,
And change in LOC.
so we might have to do surgical intervention to relieve the pressure with that shunt. Remember, the shunt could be temporary or permanent. What else? What else can happen with that shunt?
Infection,
And
Malfunctioning.
malfunctioning.
malfunctioning. Okay, so we're monitoring for that stuff. All right, so you're looking for sunset appearance of the eyes, the vomiting, the weakness in the cry. Okay, and if it's late, then you might see the bradycardia, you might see changes in the posture, the cerebral, the corticate posturing, that kind of thing. So early signs again, headache, vomiting, blurred vision, dizziness, decreased pulse or respirations, increased in the blood pressure. Pupil reaction time decreased and unequal, sunset signs, sunset eyes, changes in the level of consciousness, seizures, late signs, lower level of consciousness, bradycardia, irregular respirations, Cheney-Stokes, fixed and dilated pupils. For the shunt infection, okay, we'll see an elevation in the vital signs. The baby will be a poor feeder. They may have vomiting. They may not be as responsive. They may have seizure activity or inflammation along the shunt tract. These are the decorticate and the decerebrate posturing. Remember, with decorticate, extremities will be flexed and they'll be more inward. And with decerebrate, the extremities are extended and pronated. All right, so we were talking about falls, common causes of head trauma, okay, for these babies, falls, the motor vehicle accidents, the head injuries from sports. Okay, so mostly like football, boxing, those type of activities, pedestrian and bicycle activities. So, you know, we're doing that health promotion on wearing those helmets when they're riding bikes, seatbelts when they're in a car, and then child abuse. Causes of non-accidental head trauma. So give me 1 second. Violent shaken baby syndrome, blows to the head, intentional cranial impacts against the wall, furniture, or the floor. All right, what kind of strokes in children? So I believe the ischemic are more common than the hemorrhagic. Remember that kids can have things like, you know, sickle cell disease. They can have high lipids. So they can have things that could cause this to happen, that they're born with or that they develop, you know, as they're growing. Sorry, I got to move to my other notes. Your book doesn't exactly, or whoever wrote this PowerPoint doesn't exactly go down through the book the way it should be. So, all right. So, these aren't as common in kids as they are in adult. And A lot of kids can develop them. Usually if it's a cerebral vascular disorder, like a stroke, it's usually not seen until after the first month of life. If it's some sort of periventricular or intraventricular hemorrhage, then we would see that in a preterm infant and in an infant up to 1 month of age. So they have this sudden disruption in the blood flow to the brain. All right. It could be either ischemic or hemorrhagic. Ischemic would be more common than hemorrhagic in kids. And then what kind of things would we expect to see? So the symptoms are going to be the same. We're going to have the weakness on one side, or the hemiplegia, the facial droop, the slurred speech, and the speech deficits. If they have ischemic issues, it's probably going to be related more to like cardiac disease, diabetes, increased lipids, some sort of hypercoagulability state. So, you know, things like polycythemia or sickle cell. You probably wouldn't see smoking in them unless they were a little bit older, like teenage. Okay. But we do see a lot of obesity in the younger kids now. And so that can also play a part. And then hemorrhagic would be more associated with things like aneurysms, anticoagulants, increase in age, obesity. Again, some of the other things that it's attributed to, you might not necessarily see in this population. So you probably be looking at more some sort of disease process that the child has that would cause this. If a child were to experience an ischemic stroke, the symptoms again, or a hemorrhagic, the symptoms again would be that similar to what an adult does. So tests for these would be metabolic studies, coagulation tests, echocardiogram, and possible lumbar puncture. So the kind of things that we're going to look for in the child are, you know, neurological disorder function. So level of consciousness, vital signs, the symmetry of the head, the face, the neck, the cranial nerve function, the motor function, the reflexes, sensory function, and increased cranial pressure. I noticed that they did have the cranial nerves here in the book for you guys. Did you guys review those? I probably would take a good look at those cranial nerves and know what they are for. You're going to definitely be tested on those at some point. I don't know if you will be for this chapter, but let's see, 38 cranial nerves. So on page 1330 in your book, all right, when you're doing this nervous system, okay, you're looking at the level of consciousness, the head, the neck, the face, the cranial nerve function, the motor function, the reflex, the sensory function, and the increased cranial pressure. So with the level of consciousness, okay, we're looking for things like irritability, lethargy, all right, ability to respond to stimuli, how alert, awake, oriented are they to time and place? Do they seem confused at all? Okay, they could be confused and not respond appropriately to questions. Obtunded is a state where they're not really responding very well, and they're falling asleep unless they're constantly stimulated. Stupor is where the child only responds if they're vigorously being stimulated. And then, of course, in the coma state, we can't arouse them even with painful stimuli. So lack of a response in painful stimuli is abnormal and can indicate a life-threatening condition. So we definitely want to report that. There is a pediatric coma scale that can be used to assess the level of consciousness in children. You have to take into consideration that a child may not respond to you if your voice is not familiar to them, especially if they're not in a familiar environment. So you can use this pediatric coma scale to help you elicit the responses, okay? And that's on page 38 too. A lot of times the parent would be the first one to notice a change in their child's level of consciousness, or if you're working in some place like a group home setting or something like that, it might be the direct care. You should always listen to your direct care or the lower people on the floor that do the hands-on work. They usually know when something's not right with one of their people. And if you think you're just such a smart ass that you don't have to listen to them, it's going to get you in trouble, because a lot of times these are your eyes and ears. You have to respect them and know when they're looking out for you as the nurse. Vital signs can sometimes help. Okay, so vital signs and altered level of consciousness might give us a clue. We're looking at the head, the face, and the neck. We're looking at the shape and the size. Abnormal size or shape could indicate some sort of dysfunction. Looking at the head circumference. Okay, so in really small children and babies, you're going to measure it. You want to have a baseline and you would want to compare. Don't attempt any assessment that involves movement of the head and the neck if you suspect trauma, okay, until the cervical injury is ruled out. And you should keep immobilization of the cervical spine until that time. Now, the cranial nerves, we use these to assess nerve function. And we can get different responses based on the age and developmental level. Okay, so some elements of the adult assessment might be eliminated in a child. Alterations in the cranial nerves can be caused by compression of a nerve, infection, or trauma that causes a brain injury. We use something called the Doll's eye maneuver to evaluate cranial nerves 3, 4, and 6. And this can be helpful if you're checking the infant or an uncooperative child or a comatose child. It looks at the horizontal and vertical eye movement by turning the head in one direction and assessing to see if the eyes move symmetrically in the opposite or the other direction. For example, if you suddenly turn the child's head to the right, the eyes should automatically go to the left. Assess the vertical movement in a similar manner by flexing or extending the neck. Absence of these expected eye movements can indicate an increase in intracranial pressure. Other cranial nerves. 1 is the sense of smell, the olfactory. 2 is your optic nerve. This is looking at the way the eyes move and control of the muscles and movement of the major eye muscles. The trigeminal. This is about mastication muscles or those jaw muscles, the muscles that we use to chew with, and the facial sensations. All right. For a child, it's also the muscles that they use to suck with on that pacifier or the thumb or the bottle. Number 7, facial muscles. This is about our salivation and our taste. Okay. So we can actually give them something to taste. In the infant, we have to look at how well they spontaneously cry or smile. Number 8, the acoustic or the hearing. So how does the infant respond to voice? Or sometimes you can do like the startle effect or the moral effect where you slam something down or make a loud noise and they jump. For children, you can use the whisper test or the Rhine test or the Weber test. Number 9, the glossopharyngeal, and number 10, the vagus nerve. So these are impulses to the heart and other organs. They also are about swallowing and gag reflex. So the gag reflex and swallowing are tested as adults. For infants, we check the last time of the feeding to avoid vomiting when the gag test is tested. For number 11, the accessory muscles. Okay, these impulses are to the muscles and the shoulders of the pharynx. So the infant, we look at the symmetry of the head when the child is sitting. And in children, we investigate the same as adults. Number 12 is hypoglossal, and this is motor impulses to the tongue and the skeletal muscles. And in the infants, we'll see spontaneous tongue movements. In children, we look at them the same as adults. If you look at page 1332 in your book, it has those the picture of those sun-setting eyes for you. All right, the nurse observes a child for neurological disorders. What is the earliest indicator of improvement or deterioration of the neurological status?
B.
Level of consciousness.
Okay, good. Level of consciousness is the early indicator of improvement or deterioration of neurological function. While other choices may indicate deterioration of neurological status, level of consciousness is the first sign of improvement or deterioration. Consciousness consists of alertness, which is a wakeful state, and the ability to respond to stimuli, and cognition, which includes the ability to process stimuli and demonstrate a verbal or motor response. For disturbed sensory perception, we're looking for changes in the sensories, like the eyes, the ears, the smell, those kind of things. Monitor for the child, how well can they feel pain. Monitor the child for risk of injury secondary to changes in sensory perception. Notify the physician or the practitioner of the changes in the sensory perception. And assist child to use adaptive measures or methods to live with those changes in sensory, like eyeglasses, maximize the use of the intact senses, provide familiar sounds like voices and music. There are 5 states of consciousness. We talked about these for a minute a second ago. I'm just going to go back to them again. So full consciousness, the child is awake and alert and oriented to time, place, person. They exhibit the appropriate behaviors for their age. Confusion. We have confusion. The child is slightly disoriented, but may be alert and may respond inappropriately to questions. If the child is obtunded, they would have a limited response to the environment and they may fall asleep unless we're providing stimulation. If the child is in a stupor, they would only respond to vigorous stimulation. And the child in a coma cannot be aroused even to painful stimuli. We talked about the pediatric Glasgow Coma Scale a little bit. All right, so we're measuring the child's level of consciousness by assigning the appropriate clues, the eye opening, the verbal response, the motor response. Remember that you may have to have someone talk to them if you're trying to elicit like eye opening on command. You may have to do that with somebody's voice that they recognize, because if they don't recognize your voice, they may not open their eyes on command. Closed head injuries, okay. The brain injury will be graded on how severe it is. This can occur accidentally or purposely. If it's closed head injury, we won't have any openings. So it's blunt trauma, what we call blunt force trauma. So maybe they smashed their head into the window or into a tree or something, but it didn't actually cause an opening in the skin, but still they can have like that coop, the one where the head goes back and forth. I want to say coupe de con or something like that. Anyway, coupe, I can't say it. The head bounces back and forth. The brain bounces back and forth in the head. So they hit their head really hard on something and the brain slams into the front of the head. But then it also is going to bounce back off of the front of the head now, slam back into the back of the head, and it may go back and forth a couple of times. I think it's called coupe contra coupe. And normal behavior before the injury may or may not lose consciousness. So before they had this head injury, they were acting okay, and now they're acting different. So we're going to promote, all right, the child's welfare and teach the family, all right? So we first have to figure out how willing they are to learn, give them time to adjust to the diagnosis, repeat the information, probably more than once, teach it in short sessions. You don't want to give them too much, and you want to give them at a level that they understand, reinforce it and provide rewards when they can learn, and then use different modes of learning so that they learn it better. All right, so we're just going to do a few questions on that, and then I'll try to jump into the other chapter for you. We'll do a couple in here. We'll do a couple in Saunders. Let me know when you can see it. You can take yourselves off of mute now also if you like. Can you see it? Yes, no, maybe so?
No,
You can't see the questions?
no.
How about now?
Not yet. Yes, no.
Okay, a nurse is teaching the parent of a child who has a new diagnosis of absent seizures. Which statement by the parent indicates an understanding of the teacher, of the teaching?
Three.
Okay, good job. All right, absent seizures occur in children 4 to 12, usually disappear at puberty. They'll have a brief loss of consciousness, daydreaming, or absent attack without loss of postural body tone, dropping objects held in their hands. Most of them last less than 10 seconds. All right, so they're characterized by loss of consciousness and appearance of inattention or daydreaming. The emergency department triage nurse is assessing 4 pediatric clients. Which client is a priority for further diagnostic workup and definitive care?
Is it 3?
1.
I think 1, 2.
I think it's
That
one.
shunt can be a problem.
Can be infected.
Okay, good. The ventricular peritoneal shunt is used to treat hydrocephalus, usually placed at age 3 to 4 months. Blockage and infection or complications usually results in increased cranial pressure. The normal pulse for a 1-year-old is 100 to 160. Pulse of 78 is bradycardia, part of that Cushing's triad. I'm sorry, I called it Beck's triad. It's Cushing's. So it's the bradycardia, the slow respiration, the wide impulse rate. You also see an increase in the blood pressure. All right, meningocele is that sac-like protrusion through the bony defect that causes the meninges in the cerebral spinal fluid, corrected with surgery. Muscular dystrophy is that fiber degeneration and muscle wasting. And cerebral palsy is abnormal muscle tone. Nurses reinforcing teaching to the parent of a child diagnosed with ringworm. Okay, I don't know why they threw this one in here, but we'll do it because we're doing dermatitis skin stuff anyway, right? Which statement by the parent indicates a need for further teaching? So ringworm.
Antifungal.
Three.
It's
3.
2.
I think it's 3. Infected.
Did the eggs leave in your I don't know, I think it's 2.
3.
Wait. Further. Oh, I'm sorry. I need it for further. No, it's not 2. I'm sorry.
So 3, you guys think it is?
Yes.
Yes, because other ones are like good. That means they're understood.
Ringworm is a fungal infection, okay, of the keratin layers of the skin, hair, or nails. It's not caused by a worm infestation. It is contagious. It spreads through contact. So we have to teach appropriate hygiene, limited contact with personal items, hairbrush, treatment with prescribed shampoos, as well as topical and oral medications. So those antifungals, right? Those things that end in zol. Oh, we're going to get some skin questions in here. You want me to change this to just neuro? Or you want me to keep the skin questions in?
I think it's fine because we're doing them anyway,
Okay.
right?
The clinic nurse is reviewing self-care management of acne with an adolescent client. Which client statement indicates the need for further instructions?
One, there shouldn't be scrubbing because it'll make it worse.
Acne vulgaris is a characterized skin disorder characterized by obstructed sebaceous glands. Bacteria can consume and metabolize the obstructed sebum, and the metabolic products cause inflammation, pustules, papules, and nodules. Acne usually develops during puberty, and multiple factors influence its development. Treatment includes topical oral medications such as tretinoin or retinol A, benzoyl peroxide, isotretinoin, Accutane, and oral contraceptives. Antibacterial soaps are harsh and ineffective, increase the pH of the skin, and can dry the skin. They should use gentle, mild facial cleaners. And then the other ones were correct, all right? Using a non-comedogenic skincare product to avoid new lesions, maintaining a healthy lifestyle, and refraining from squeezing, picking, or vigorously scrubbing the lesions. The nurse is triaging for clients. Which client should the nurse assess first?
One.
Ooh, one.
Okay, why one?
Botulism.
Botulism.
Botulism. I didn't even read the rest.
Always read the rest, please, because it doesn't have to be that answer. So make sure you read your questions thoroughly. If you practice reading them thoroughly, you'll read them more thoroughly on exams. Botulism, that's that food poisoning. It's often found in honey or raw honey. Okay, and it colonizes the GI tract and causes it to release toxins that cause rapid life-threatening paralysis. Early clinical manifestations include constipation, feeding, poor head control, diminished reflexes, and it can progress rapidly to respiratory failure and arrest. The nurse is giving instructions related to an antibiotic eye drop to the parent of a 5-year-old with bacterial conjunctivitis. Which instruction is most important?
Four. Four.
Okay, hand washing because it's highly contagious, right? Good. Newborn has a large myelomeningocele. What nursing intervention is priority?
Two.
Okay. That's what it looks like. All right, so we have to prevent that sac from rupturing. We're going to cover it with that sterile moist dressing to decrease the risk of infection and also keep it safe until the surgical repair can occur. We would place them in the prone position with the face turned to the side.
Mm-hmm.
The nurse has provided instructions about home care management for the parents of a child diagnosed with rotavirus infection. Which statements by the parent indicate that teaching has been effective?
Hand washing.
Select all that apply.
What?
Oh no, I said it's a select all that apply.
Yeah.
I like two at this house right now.
2? Somebody said 2, or that was somebody talking in the background?
5.
I think number 2.
Final answer?
Yeah.
Okay, good. All right, so this is a GI virus. Okay, it's going to cause diarrhea. It's spread through the fecal oral route. All right, so contact with food, diapers, hands. So we have to have meticulous hand washing here. It's going to be a foul smelling, watery diarrhea. So we have to watch for dehydration. Vaccination is available and has to be given before the child is 8 months old. Antibiotics not effective because it's a virus. What discharge instructions should the nurse provide to the parents of a 2-year-old with group A strep pharyngitis?
1.
Yeah, 1.
Four.
Should replace the toothbrush.
2. Liquids and soft dye. I don't know if they have to keep them for a week. I think they need a clearance from the doctor. I think second or third when they start the antibiotics, they can go back.
I thought it was like, yeah, 24 hours after.
24
Yeah.
hours after they've been
So
on.
it's definitely down a week. I don't know if we should be giving them throat lozenges because they only 2. So I don't know if they should be sucking on like.
Good. All right, I'm going to change this a little bit because this is bringing us infectious disease, and you guys are on tissue perfusion, and I thought it was bringing us something different, so I'm going to just change it a little bit. Let's go to these ones. These are all neuro, I believe.
Okay.
All right, the parents of a child recently diagnosed with cerebral palsy asked the nurse about the limitations of this disorder. The nurse responds by explaining that the limitations occur as a result of which pathophysiological process.
The 3.
We'll see. All right, this is a chronic disability characterized by impaired movement and posture resulting from abnormality in the extrapyramidal or pyramidal motor system. Meningitis is number 1, an infectious disease of the central nervous system. Encephalitis is inflammation of the brain that occurs as a result of a viral illness. Down syndrome is an example of a congenital condition that results in moderate to severe intellectual disabilities. Good. The nurse notes documentation that a child is exhibiting inability to flex the leg when the thigh is flexed anteriorly at the hip. Which condition does the nurse suspect?
Meningitis.
Okay, and one of these things is not like the other, but this is one of those signs, right? Kernig's or Brzezinski, which one?
Brzezinski.
Findings.
Okay, Kernig's. Meningitis is an infectious process of the central nervous system caused by bacteria and virus. The inability to extend the leg and the thigh flexed anterior at the hip is a positive Kernig's sign. Noted in meningitis.
Oh,
Kernig's
sorry.
sign is not seen with other things.
The other one is like bending. Neck bending is the one. Sorry.
Brodinsky. That's Brodinsky, bro.
Yeah.
A mother arrives at the ER with her 5-year-old and states that the child fell off the bunk bed. An head injury is suspected. The nurse checks the child's airway and assesses the child for early and late signs of increased intracranial pressure, which is a late sign of increased cranial pressure.
Bradycardia.
Bradycardia.
Pretty.
4.
Right? 4, bradycardia. All right.
We just talked about that.
Good. All right, so head injury is the pathological result of any mechanical force to the skull, scalp, meninges, or brain. It can cause bleeding in the child and increased intracranial pressure. In a child, early signs include a slight change in level of consciousness, headache, nausea, vomiting, visual disturbances, and seizures. Late signs include decreases in level of consciousness, bradycardia, decreased motor and sensory responses, alterations in pupils and reactivity, the posturing, the decerebrate and decorticate, the Cheney-Stokes respiration, and coma. The nurse is assigned to care for an 8-year-old with a diagnosis of a basilar skull fracture, a basilar skull fracture. The nurse reviews the pediatrics prescriptions and should contact the pediatric to question which prescription?
Do section then?
Is it 3?
Why?
Because,
And increase the pressure.
I mean, I think it's 3, section,
Why is it
Um,
3?
because,
Tricia?
because
She has a skull fracture, and with the introduction of the nasal tracheal can possibly increase CSF.
Pressure.
ICP.
Yeah,
I mean,
ICP.
ICP.
Okay. The basilar skull fracture is a type of head injury. Nasal suctioning is contraindicated because of the injury. There's a possibility that the catheter would enter the brain through the fracture and create a high risk for infection. So that's why no suctioning. It's not for the increased pressure. It's because of the increased risk of another infection because of where the fracture is located. You could technically enter in through that fracture and go into the brain while you're suctioning. But it was still a good try on your, at least you're going in the right direction there. The nurse is reviewing the record of a child with increased intracranial pressure and notes that the child exhibited signs of decerebrate posturing. On which assessment is the child, the nurse expects to know which on assessment of the child, the nurse expects to know which characteristics of this type of posturing. So remember
3.
one, the decerebrate, one of them is decerebrate and
The
decorticate.
extension,
One of them represents where everything is turned inward, and one of them represents where everything is turned outward.
outward. So it's 3, it's outward. Yeah. Extension and phonation, something. Because one is the hug, one is the straight, whatever.
So
Okay.
decerebrate posturing is characterized by rigid extensions and pronation of the arms and legs, and decorticate posturing is characterized by abnormal flexion of the upper extremities and extension and abduction of the lower extremities. Good job. Child is diagnosed with Reye's syndrome. The nurse creates a nursing care plan for the child and should include which intervention in the plan?
4.
It's 4. 4.
Good. Reye's syndrome is a type of encephalopathy following a viral illness characterized by cerebral edema and fatty changes in the liver. Supportive care should include monitoring and managing cerebral edema, decreasing stimuli, providing a quiet environment, decreased stress on the tissue and the neurons. Hearing loss and urine output are not affected, and changing the body every 2 hours will not affect the edema. The child should be positioned with the head of the bed elevated to decrease the progression of cerebral edema and promote the drainage of cerebral spinal fluid. So what degree would we want the head of the bed elevated?
30.
15 to 30. The nurse creates a plan of care for the child at risk for tonic-clonic seizures. In the plan of care, the nurse identifies seizure precautions and documents which item needs to be placed at the child's bedside.
I mean,
They can be
yeah, 4.
Good. A lumbar puncture is performed on a child suspected to have bacterial meningitis, and cerebral spinal fluid is obtained for analysis. The nurse reviews the results of the CSF analysis and determines that which results would verify the diagnosis.
3. Yeah, it's 3.
Meningitis is an infectious process caused by bacteria and viruses. results as complications of neurosurgery, trauma, infections. It's diagnosed by testing cerebral spinal fluid through a lumbar puncture. Findings usually include elevated pressure, turbid or cloudy central spinal fluid, elevated leukocytes, elevated protein, and decreased glucose. Nurses planning care for a child with acute bacterial meningitis based on the mode of transmission of this infection, which precautionary intervention should be included in the plan of care.
Four.
They need to be isolated for first 24 hours.
Okay, good. They have to be isolated for the first 24 hours after the antibiotics are started. The nurse is creating a plan of care for a child at risk for seizures. Which intervention apply if the child has a seizure?
1, 3,
Move the furniture.
5,
That's it.
oh, you. What happened?
The nurse notes documentation that a child is exhibiting an inability to flex the leg when the thigh is flexed anteriorly at the hip. What is that?
Meningitis.
Yeah.
No, what is the sign?
Oh, that's
Decote.
Kennen something.
Panic
Kennen
sign.
sign.
Perfect sign, okay? We know it's for meningitis, good. Mother arrives at the emergency. This is the same question.
We just did that.
already. We did that.
Giving us the questions again. All right, let's flip it up then.
Okay, this one we didn't do.
These other ones here, and then we're gonna go back to lecture. All right, let's see. Let me end this. All right, we'll skip over the ones we did already. Okay, a child with autism spectrum disorder is being admitted to the acute care unit. What is the most important nursing action?
Semi-private room near the nursing station. Child in a semi with another. Outside, put them up with the child. We can.
I don't know.
I'm not sure. I think
Can
it's
it be 4? Like with another, I don't know. Oh, they don't give it. Oh.
Maybe 3.
So I don't think you're gonna put them in another room with another child.
Yeah, that's what I was thinking, because they don't really
Probably in
play
an
with-
area
they
where
don't-
it's not too much stimulation. So I'm thinking 1 might be the correct answer here, but it might be wrong. But I'm thinking with autism, we would want to put them in an area where it's not too much stimulation and they don't get along well with other people. So
Yeah, that's what I was thinking. So I said,
if I had to guess, that's what I'd be guessing towards.
Go
away
with
from
one.
the patient.
Okay. A 2-year-old is diagnosed with atopic dermatitis, eczema. Which instructions should the nurse teach the parents?
Four, three,
Keep the nurse
1, 3, 4.
one, 3, 4.
1 emollients after the baths. Okay, that's your final choices?
Yeah.
Okay, good. Atopic dermatitis, known as eczema, is a chronic skin disorder characterized by pruritus or itching, erythema, and dry skin. Exact cause unknown, associated with impaired skin barrier and immune response to those allergens. So we have to alleviate that itching, keep the skin hydrated to reduce the scratching. Fingernail trimming would help prevent secondary infections. We're using tepid baths because that helps eliminate itching. Skin would be patted, dry, not rubbed. Emollients to help bring that moisture in. What else is this associated with?
Dry skin. Oh,
Eczema. What is it associated with?
um,
Asthma.
Right.
oh,
Yeah, that's right.
oh.
A
Okay.
newborn has a large myomeningeal cyst. We did this one, right? Cover the area with saline.
Mm-hmm.
I don't think we did this one. The nurse is planning care for an 8-year-old client with a mild cognitive impairment hospitalized for diagnostic testing. Which of the following interventions are appropriate to include in the plan of care?
1, on 3, guessing 5, revisual, and transform to limits, by limit setting. I don't know. Limit setting.
Yeah, I think that's it. I agree.
What is, oh, that limit setting threw me off, the like, what's,
So if the client is cognitively impaired, they may present with self-injurious behaviors. So we're doing limit setting with these clients. Usually when you see anybody that's cognitively impaired, that's going to be something that's included in their plan of care. Because they may not understand what you're doing to them or why, and they may just think that you're trying to hurt them. Sometimes they do this for attention seeking. Sometimes they do it to get their way. All right, 7-month-old is admitted to the unit with suspected bacterial meningitis after receiving an initial dose of antibiotics in the emergency department. Which frequent assessment of which of the following is most important in the plan of care?
meningitis.
Number 2.
All right, number 2. The fontanelles. Everybody agree with that?
I'm not sure.
It says, point SS. Okay.
The pupils. I'm not sure. So I'm not gonna-
Okay, so if you're not sure, then let's go with somebody who thinks they're sure.
Yes.
Good job. All right, bacterial meningitis is inflammation of the meninges and the brain and the spinal cord caused by infection. Manifestations in infants of or children less than 2 include fever, restlessness, and a high-pitched cry. A common complication is hydrocephalus, an increase in intracranial pressure, resulting from obstruction of the cerebral spinal fluid flow. All right, so for these patients, remember, we're looking at the fontanelles and we're looking at the head circumference.
Mm-hmm.
All right, so that increased pressure is caused by the obstruction of that cerebral spinal fluid. And the increased pressure can progress to permanent hearing loss, disabilities, and brain damage. So the pulse pressure, remember that widening of the pulse pressure, that's one of the signs in Cushing's triad, which Cushing's triad is the widened pulse pressure, the bradycardia, and the respiratory depression. We see that in that's a late sign of increased cranial pressure. All right, the reason why it was the fontanelles over that is because the fontanelles are an earlier sign. So if it asked you for a late sign and it was going back and forth between the fontanelles and that widened pulse pressure, you would want to go with the widened pulse pressure or those signs of the Cushing's triad. All right. The nurse is preparing for admission of a 9-year-old client with the new onset of tonic-clonic seizures. It's important for the nurse to ensure what is in the room.
Suction,
Oxygen,
padding on the bedside field. Oxygen. 3.
3. Yeah, that's it. I don't.
Okay, good. All right, so client safety, protecting the airway and improving oxygenation, turning the client on the side, oral suctioning, patting those side rails. We're not going to restrain them. We're not going to put anything in their mouth. You might lose your finger trying to put something in their mouth. The nurse reviews new prescriptions for a 6-month-old client with bacterial meningitis. Which action is the priority of care?
Prescription doesn't. Receive new prescription.
Might be number 1.
Yeah, because it says prescription.
The medication.
Administer the medication.
Well, they're all prescriptions, right? The doctor would prescribe all of these things.
The priority.
You're asking
maybe
priority of care. So which one is going to help your patient the most?
Maybe 4.
Number 3.
Oh, maybe
It's on
3.
the
Because then it
medication.
3. Then it low stimulation environment.
Number 1.
So I
I'll
don't
go
think
with
that
1.
your answer choice with 1 was wrong. And I do think that you're going to do everything here. 4 is going to tell us if it's resolving or not. Okay, and we are going to do 3, but we do have to counteract this infection, or it could become life-threatening. So it's
one.
our priority, most likely. We are going
One.
to do 2 because the patient could have seizures. But I feel like we have to attack the infection first, okay? I feel like that is a priority, so I don't think you were wrong. I just didn't want you picking an answer because it said new prescription. I want you to understand these are all prescriptions that might be given to you.
Don't we start the
I'll do
antibiotics right away to control the bacteria?
We need to stop the bacteria from growing. So we are going to do everything there. But we would do 4 after we give the antibiotics because that's going to tell us if it's improving or not. Because we would expect that circumference to start going down now once the infection starts getting better. If it's not going down, then the baby may not be responding to the medication. A nurse is teaching a parent of an 8-month-old infant who had febrile seizures about management of future fevers. Which instruction is appropriate to include in the teaching?
Febrile seizure.
Febrile seizure.
Okay, febrile seizure, management of future fevers.
I'll do 1.
8-month old, yeah, we could give ibuprofen.
The ice will cause them to shiver. So meaning that it will cause more harm than good sometimes. That's what I think for 4. I'll do 1. Along with the tepid bath sponge.
Good job. All right, so for those of you that can stay on here, I'm going to try to tackle this tissue integrity because I feel like that is probably going to be harder for you to comprehend than the skin or the integumentary. You got 3 chapters, it looks like, on this exam, 38. Is that right? 38?
45, 37, 38, 45.
37.
Yeah, so we'll see what we can get to here.
Infection. Integrity.
All right, so when we look at kids, we have to also take into consideration tissue integrity. And this is about our body. Can you guys see the slides or not?
No. Okay, we see it now.
Still recording. Okay, we're still going. All right, and I put up the recording from yesterday already on YouTube. It should be available by now, hopefully. All right, so tissue integrity refers to how our body is able to maintain certain physiological processes. And with kids, if they have an alteration, you have to be familiar with the different integumentary disorders that they might experience. So alterations that occur in kids are often due to exposure of infectious microorganisms, some sort of hypersensitivity reaction, hormones, or an injury. And some of the integumentary disorders are mild or self-limited, like a mild abrasion. Other things like atopic dermatitis are chronic and have to be managed consistently. If the integrity alteration is severe, it could be life-threatening. That could be in the case of something like a full thickness burn. Or if they're chronic and severe, they could have a major impact on the child's physiological and psychological status. Kids who are at risk, nurses have to be familiar with them, and you have to be familiar of what kind of skin disorders that you might expect to see in infancy, childhood, and adolescence. So you should already know that skin is the largest organ in the body, and it's going to help us protect our tissues that are underneath it. And when we look at the patient's skin, it really tells us an overall picture of the body. It's also important for us in order to feel things like pain, heat, cold, and to regulate our body temperature. For the infant, their skin is going to be a lot thinner than the adults, and the blood vessels are really close to the surface because they don't have as much subcutaneous fat. So this allows them to lose heat through the surface much quicker than that of the older child or the adult. It also allows for certain substances to be absorbed through the skin more easily than they would in an adult. Bacteria can also easily gain access through that skin and the younger child's skin more easily than it can penetrate through the adult skin. So if that baby skin contains more, that baby skin will contain more water than the adult. Remember, the baby is about 90% water. So that causes the epidermis to be bound not quite as tight. And the friction can cause any kind of friction can cause separation of the layers easily. All right, so that would cause the skin to blister or break down much easier than that of an adult. Also, in a baby, there's not as much pigmentation. All right, so that puts the baby at a higher risk for skin damage from ultraviolet radiation. Over time, their skin will become tougher and it will become less hydrated and less susceptible to bacteria. It will start to become thicker and it will become more like that of an adult as the child increases towards their teenage years. We have something called keloids. These formation of these is more common in someone with dark skin and lighter skin, and it's like this buildup of skin or cartilage that it kind of sticks out and it doesn't really have much use. It's not very pretty, all right, and it grows on the outside of the skin, all right. Also, with dark skinned kids, they can have hypopigmentation or hyperpigmentation if they have some sort of dermatological condition. It's usually temporary, but it can be permanent if the condition involves the skin and it happens for a long time. Also, darker skinned children will have more prominent papules. So if they have like something on their skin, it'll be more round or more pustular. Also, their skin can have more of a follicular response to something than someone with lighter skin. And then the hypertrophic scarring and the keloid formation can also occur more in these kids. So that would be there's a picture of that on chapter, figure 45.1 in your book on page 1650. All right, so what causes these integumentary disorders could be things like exposure to infectious microorganisms, hypersensitivity reactions, changes in the hormones, some sort of genetic predisposition, or some sort of injury or trauma. Also, with babies, their sebaceous glands or their sweat glands will produce a sweat response to emotional stimuli and heat. They're not fully functional at birth. They will become more functional as they get into the middle childhood. And until that time, the temperature regulation is not as good as that of an older child or an adult. So part of it is in response to those sweat or those sebaceous glands. So in order to evaluate these kids, we're going to do things like blood tests. We might do a CBC looking at hemoglobin, hematocrit, and white blood cells, especially the percentage of the white blood cells and the platelet counts. So when I think about the white blood cells, I think about never let monkeys eat bananas. That's the way that they are in the body. So neutrophils, lymphocytes, monocytes, let's say never let monkeys eat bananas. So neutrophils, lymphocytes, monocytes, eosinophils, basophils. We're looking at the different values according to the age and the gender. The white blood cell differential helps us evaluate the source of the infection. And then eosinophils might be elevated in a child that has something like atopic dermatitis. So usually if it's some sort of allergic response, we might see it with the eosinophils. The ESR, the erythrocyte sedimentation rate, we usually see this with some sort of autoimmune response. We can see it with infections also, but usually why we see it with the autoimmune response is because usually with those, there's some sort of inflammatory response. So this will be usually elevated. The potassium hydrochloride, this helps us identify different fungal infections. And so we can do a scraping of the skin on a slide, and then we add the potassium hydroxide to it, and then we look at it on the slide. Also for things like skin diseases like scabies and stuff like that, sometimes we'll do scrapings of the skin and we look at it on the slide to see if we can actually see those little mites that go underneath your skin and bite you are on there. The immunoglobulin IgE, this is usually measured for atopic dermatitis. It's often elevated in an allergic response or the atopic disease, or it could be increased also if the client takes systemic steroids or corticosteroids. The patch or the skin allergy testing, this we can do sometimes if the child is at risk for certain types of allergic responses. So sometimes they'll do this just to test different allergens. Maybe the child's having an allergic reaction to something and they don't know what it is. So they might do these patch or these spot tests on the skin. They're usually done in the doctor's office. They introduce the child to a small amount of the allergen and see if they have a response. And you'll have to have like something there in case they have an anaphylactic response. So they use like a little prick of the skin with the allergen and see. A lot of times they'll look for atopic dermatitis or contact dermatitis with this type of testing. Culture and sensitivity, we may do this before we prescribe something in case the person has something like MRSA or VRE or even a staph infection. We want to make sure whatever we're going to give it, the patient, for this infection is going to be effective, because otherwise the infection is going to continue to grow and it'll turn into sepsis or something. So we'll culture the wound. We may start the client on antibiotics, and then once the culture comes back, if whatever we started them on is not sensitive to the infection, then we're going to change the antibiotic. The skin biopsy, they would take a biopsy of the skin and test it. And the wood lamp, I forget what that is. Let me see if I can find that. It's some type of light that they use. I've seen it before, but I can't remember off the top of my head what it is. So it's a small handheld device. It uses a black light to illuminate areas of your skin. And it can detect like fungal infections, bacterial infections, and pigment disorders like as vitiglio. Oh, this is the same test that they also use for the if you had like a scratch cornea. So some of you might be familiar with that. Different terms you should be familiar with, and these describe like different vesicles on the skin. So macules, papules, annular, pruritus. So you're going to use these terms when you're documenting. All right, so you should be familiar with what the different definitions are. Pruritus, vesicle, pustule, scaling, plaques, hypo or hyperpigmented, and erythematous. Give me 1 second. Guess your book doesn't give definitions of those for you. I don't see them popping up. All right, so the macule is going to be flat, distinct, discolored area of skin. It's usually less than 1 centimeter. The papule is going to be raised, and it might have a like a pimple appearance. All right, and it's usually part of a rash on the skin, but it doesn't usually produce pus.
I see the papules is on page 1650. I don't see the macules though yet.
50, you see them?
I see the papule is on 1650 under where it says differences.
Okay,
in
yeah, I see that one. It says rounded, non-pustular, which is what we described.
elevated on the skin. I don't see
Okay.
the macules though anywhere yet. Anyway.
So annular are going to be ring shaped, and that's really kind of like the ringworm. Pruritus, of course, is itching.
Golden.
For the vesicles, these are small fluid-filled areas. And the pustules are going to be they're going to be fluid-filled, but they're going to be more with pus. Whereas the papular one doesn't have any pus. Okay. Scaling and plaques, these are what you're going to see with like the atopic dermatitis. You'll see these like on the elbows of the skin, sometimes on the thighs or inside the groin area. And of course, pigmentation has to do with color. Hypo meaning low, hyper meaning increased, and then erythematous is usually red. All right, so what type of infections will we see in the skin? You're going to see things like impetigo, folliculitis, cellulitis, MRSA, staph. You should know what these look like and how they affect the skin, okay? Because they do ask questions about that, especially with the cellulitis, okay? So impetigo, folliculitis, and cellulitis are usually self-limited, and if they're treated right away, they don't usually become severe. The impetigo is usually recognizable skin rash. It's usually very contagious. Okay, so there's some sort of trauma to the skin, and then the person develops this infection. All right. With the impetigo, a lot of times you'll see it on the around the nose and the facial areas, the mouth, and on younger children. And you'll see a lot of parents will put stuff on it like the purple stuff. I forget what they call it, iodine or mercurochrome. Mercurochrome, I think, is yellow. Those skin infections are usually caused by staph A, B, hemolytic strep, okay, and this is normally found on the flora of the skin. Folliculitis, this usually is an infection of the hair follicle, and it usually is caused by occlusion of the follicle. It can sometimes be part of poor hygiene or prolonged contact with some sort of contaminated water or a moist, macerated environment or use of occlusive emollient products. Cellulitis, this is a localized infection and inflammation of the skin and subcutaneous tissues. It's usually preceded by some sort of skin trauma. If they have periorbital cellulitis, that's usually caused by bacterial infection of the eyelids or the tissue around the eyes. And it allows the bacteria to get into the skin through an abrasion, laceration, insect bite, foreign body, or impetigo lesions. So any one of these can allow the cellulitis to enter the skin or the staph A to enter the skin. That's causing the infection. The periorbital cellulitis can also be caused by things like sinus infections or strep pyrogenes that are around that area. Okay, so the bacteria is going to cause an inflammatory response, and you'll see redness and swelling and infiltration of the skin. And usually the skin will have like a shiny sort of weeping look to it with the cellulitis. The Staphylococcus scalded skin syndrome. This is caused by Staph aureus. There's a toxin produced which causes exfoliation of the skin. It has an acute onset, and then you'll have reddening of the skin and tenderness, and it'll look like scalded skin. It's most common in babies, and we don't usually see it after the age of 5. And then MRSA, okay, community acquired MRSA especially. That concerns us, okay, because it can spread. We'll usually see this in areas where there's a lot of people living. So you might see it where they share towels, do team sports like daycare camps, assisted living facilities, those kind of places. They get this infection and it doesn't respond to therapy. And then we culture it and we determine that the client is methicillin resistant to the Staph aureus. Okay, so we call that MRSA. So they'll have to have broad-term antibiotics. For most bacterial skin infections, we're going to give some sort of topical or systemic antibiotics and appropriate hygiene. For periorbital cellulitis, we would use IV antibiotics during the acute phase. For complications, you can have bacteremia and orbital cellulitis, all right, which would involve more infection further into the eye. So we have to be careful about that. With impetigo, you'll see pictures of that on 45-2. You can see it's all around the nose and the mouth. They have that honey-colored crusting. So if you do see any changes in the eye, like conjunctival redness, a change in the vision or pain when they move the eye, any sort of eye weakness or paralysis, you would want to let the doc know, because it could be progressing to orbital cellulitis from the periorbital. These kids can also get fungal infections. Tinea is fungal disease of the skin, and that can happen on any part of the body. All right, so you'll see things like tinea pedis, fungal infection of the feet, tinea corpus, fungal infection of the arms or legs, tinea versicolor. This is fungal infection on the trunk and the extremities. Tinea capitis. This is fungal infection on the scalp, eyebrows, or eyelashes. And tinea crucis. This is fungal infection of the groin. So I have in the past seen them test on these. I would know these. Three organisms are most responsible for tinea are Epidormophyton, Microsporum, and Trichophyton. And there's another one called Malacia furfur, which causes something called tinea versicolor. Remember, that's on the trunk and the body. All right, the Candida albicans, these can cause an infection of the skin, especially if it's a warm and moist area like the diaper area. All fungal skin infections can occur year-round, but tinea versicolor is more common in warm weather. Management of fungal infections would include hygiene and antifungal agents. So we talked about a couple of these. Remember, with the tinea corpus, the ringworm, that's where you see that annular or that ring-like lesion. I probably would review that chart on 45-2, table 45-2. I would probably look at things that they probably are going to test you most on would be like the diaper rash. What kind of treatments would we expect? You know, is it dermatitis? What would we look at to determine, you know, from a regular fungal infection versus a possible staph? The ringworm, the athlete's foot, and maybe the capitis. These are the ones that you're going to see more often. Just looking for these viral ones. Probably ringworm. Since your book goes down, this PowerPoints do not match what your book does. All right, so 1307 are these viral exanthems, okay? And that means a rash or a skin eruption. Immunizations have led to a decrease in the incidence of certain ones, such as measles, rubella, varicella. Typically, children with these are cared for at home. They could be hospitalized if it, got to that point where the symptoms were out of control. So these children are going to have a rash, probably a fever. They may have some respiratory complaints. You would want to find out any exposure to childhood illnesses, and you would also want to check for rashes as well. So for the viral exanthems of childhood, those are on page 1307, table 37.4. Those are going to be rubella, rubeola or measles, varicella zoster or chickenpox, roseola infantum or sixth disease, erythema infectiosum or fifth disease, which they like to test on, hand, foot, and mouth disease. Now, you may see some test questions on this. I'm not sure, but this is fairly new. It's an old disease, but now it's making a reappearance. So for these, we're going to focus on reducing the fever, relieving the discomfort, protecting that skin integumentary, and encouraging hydration. We give antipyretics, anti-itch drugs as we need. We're anti-puretics. Non-pharmacological interventions would be things like reducing fever, tepid sponge baths, cool compresses. And then, of course, trimming those fingernails to prevent scratching, itching, and those kind of things. And then herpes simplex, okay? Most of these kids get that from their parents. It's passed on during childbirth, and it's the gift that keeps on giving. All right, so whenever they have active lesions, they're definitely going to be contagious. So if you're teaching a parent about, applying treatments and stuff like that, you want to make sure that they're using gloves and stuff like that if they have lesions, and that they're watching for spread and for, symptoms of the lesions. The lesions can be painful. Hopefully, these aren't something, this could happen to a child also if they were exposed to sexual abuse. Right, the child could also develop not only the herpes but another type of sexually transmitted disease. We did talk about these. These are risk factors for developing that community-acquired MRSA. So turf burns, sharing towels, especially those wet towels in the locker room, anything with participation in team sports, and attendance at any sort of outdoor camp or daycare. We talked about these different fungal infections. Okay, we have the tinea capitis, that's going to affect the scalp. The tinea cruris, that's going to affect the groin. The tinea pedis, that's going to affect the feet. And the corporus is going to affect other parts of the body. The versicolor, that's going to be the trunk, okay, and the upper body. The nurse is assessing a child who presents with patches of scaling on the scalp and central hair loss. What fungal rash does this condition signify?
D.
D, tinea capitis is on the cap of us. This is our head, right? Patches of scaling on the scalp and central loss are signs of tinea capitis. Signs of tinea cruris are erythema, scaling, and maceration of the inner thighs. That's in the groin area. Tinea versicolor will present a superficial tan or hypopigmented oval scaly lesions on the upper back, chest, and proximal arms. So we're going to see that on the upper trunk. And then the tinea corporus is that ringworm-like structure, and it's going to have that annular shape, right? That ring-like shape with the raised scaling that looks like a ring. All right, types of inflammatory skin conditions. So we have acute hypersensitivity reactions like diaper dermatitis. Contact dermatitis, erythema multiforme, and urticaria. And the atopic dermatitis, this is a chronic hypersensitivity. The seborrhea and the psoriasis are also chronic inflammatory skin disorders that do not occur though as the result of that hypersensitivity. So for the dermatitis, this is an inflammatory reaction of the skin. And for the diaper dermatitis, you're going to have that inflammatory reaction in the area that's covered by the diaper. It's due usually to prolonged exposure of urine and feces, and it can eventually cause skin breakdown. So we're looking at the area for erythema maceration. Usually if it's diaper dermatitis, it won't have a bumpy rash. It'll be more of a flat rash. It can start to look red or shiny. And it may also have papules, or it may not. If it becomes untreated, it'll start to spread. And then sometimes we get an overgrowth of the fungal infection there. So we're going to manage this with topical products like A&D, zinc oxide, or petroleum to give that barrier to the skin. If it does become fungal, then we would have to treat it accordingly. We should discourage the parents not to use any type of baby powder because of the inhalation risk, and that can result in some lung problems. So we would want them to change the diapers frequently, don't use rubber pants, wash the area with a soft cloth and no harsh soaps, avoid any baby wipes or anything with fragrances in them. To let the rash heal, okay, you could allow the child to go without diapers. It says you could blow the area dry using a blow dryer, okay, not your breath. And it should be on like a cool setting for 3 to 5 minutes. For the atopic dermatitis, also called eczema, this is in the atopic family with asthma and allergic rhinitis. It usually will appear before the child is 2. It often is associated with food allergies although not all children with atopic dermatitis will develop the allergic rhinitis or the asthma. We'll see chronic itching, and that causes psychological distress. It also can affect the child's self-image. Their sleep and concentration can be affected. It creates a lot of stress in the child, and they can develop bacterial super infections because of the constant scratching. So we need good skin hydration, topical steroids, sometimes immunomodulators, oral histamines, and antibiotics if the infection does occur. So with this, you're going to see extreme itching, inflamed, reddened, swollen skin. It will relapse in nature. It may occur in response to food allergens like eggs, wheat, milk, peanuts. Other environmental triggers include mold, dust mites, cat dander. And it may appear more frequently with frequent like high or low temperature changes, perspiration, exposure to skin irritants, and stress. Sweating makes it worse. Make sure with these kids that you listen to their lungs for wheezing, okay, because of the asthma. You're going to test them with IgE, and you might do like the skin patch or the allergy prick testing, that skin prick testing. Remember, for them, it's hydration, skin integrity, and prevention of infection. For these patients, Vaseline or generic petroleum is super inexpensive, okay? And so if you're trying to hydrate the skin, that might be an option. Contact dermatitis, this is a cell-mediated response to some sort of exposure to an antigen. All right, so it reaches the cell, and during the second phase or the second contact, it'll start to release these inflammatory mediators, and we'll see an allergic response within 24 to 48 hours after the person comes in contact with the subject that they're, or substance that they're allergic to. One common cause of contact dermatitis in kids is exposure to things like poison ivy or poison oak. Also poison sumac. All right, so direct or indirect contact with the plant found in the leaf stems and roots results in an allergic reaction. So if they do get exposed to this plant, the first thing you want to do is give them a shower and remove any potential film that might cause additional problems. So the quicker you can get that film off, the better. It's not contagious, but it can spread to other parts of that person's skin. Scratching does not spread it, but it can cause infections because of the damage to the skin. The erythema multiforme, this is not that common in kids. It is a hypersensitivity reaction, and it will often occur in response to things like Epstein-Barr syndrome or virus, or certain drugs like sulfa drugs, penicillin, immunizations. Also, it can happen with some food reactions. Stevens-Johnson syndrome and toxic epidural necrolysis are the most severe forms of erythema multiforme. You guys are familiar with those? These can happen with certain drugs when we put people on certain drugs, especially the Stevens-Johnson
Aspirin.
syndrome.
Any drugs containing aspirin?
I'm sorry?
Aspirin for Steven Johnson, especially after like a viral infection.
That's one of the antibiotics, I believe, for Steven Johnson.
So it's quite a bit of drugs that can actually cause this Steven Johnson syndrome and the epidural necrolysis. There are antipsychotics that can cause it. It can be caused by certain antidepressants, I believe. So it's quite a few drugs that could actually cause this. Those two are the most severe forms of this erythema multiforme, and they're both life-threatening. So Steven Johnson syndrome and toxic epidermal necrolysis. Box 45-1 in your book, I believe, will give you a list of some of the drugs that put you at risk for this. On page 4514 is a picture of it. So for this, we would discontinue the food or the drug that's causing the issue. We're going to give lots of fluids, analgesics, antihistamines. Urticaria, this is often called hives. It's a type 1 hypersensitivity reaction, and it's usually in response to some sort of allergic reaction. So it's going to be initiated by the antigen antibody response of histamine, and the vasodilation and increased vascular permeability, all right, causes that erythema and those wheals to develop. It usually starts fast, and it can go away in a few days, or it could take up to 6 weeks. So common causes are reactions to food, drugs, animal stings or bites, like bee stings or a bee bite, whatever you want to call it, especially the ones that leave those stingers in. Infections, environmental stimuli, and stress. And then therapeutic management would focus on removing the cause of the reaction and giving histamine, steroids, or both. You want to pay attention, if your patient has this type of reaction, because it may be followed by compromise of the airway and breathing, and you may have to give epinephrine, steroids, and oxygen in order to help this patient return back to normal. Seborrhea, this is a chronic inflammatory type of dermatitis. It can usually happen on the skin or the scalp. It's often referred to in babies as cradle cap. They can also have seborrhea on the nose, the eyebrows, behind the ears, or in the diaper area. It usually resolves itself over a few weeks or months. Adolescents can have seborrhea on the scalp or dandruff, and on the eyebrows, the eyelashes behind the ears, and between the shoulder blades. So usually we'll treat this with steroids, creams, lotions, anti-dandruff shampoo, all right, and sometimes antifungals. Psoriasis, this is a chronic inflammatory condition of the skin. It can have periods of remission and exacerbation. They say that control is possible with conscientious therapy. It's an immune-mediated disorder, and usually they have some sort of genetic predisposition to it. It's usually diagnosed in childhood, and it's caused by hyperproliferation of the epidermis, and rashes develop at the sites of the mechanical, thermal, or physical trauma. Management includes skin hydration with emollient creams, use of tar preparations, topical steroids, and ultraviolet light. And the light has been used with some success in children that have severe psoriasis. So for this, you're looking at those areas of the skin. They're going to look like little plaques, and they could be anywhere on the skin. Mineral oil helps with them. All right, we went through the contact dermatitis, but I'm going to go through the slide again just to try to sink it in. All right, so there's a lot of things that can cause it. Antigenic substance exposure. We talked about that. What we didn't talk about is allergy to nickel or cobalt. So these items can be in jewelry, clothing, hardware. So sometimes when people wear certain rings, necklaces, or certain clothes, you'll see them break out around their neck or their wrist or their finger where that jewelry is being worn. And then exposure to those plants of poison ivy, oak, and sumac. Complications are secondary bacterial skin infections and lichenification or hyperpigmentation of the skin. Acne, this is a common condition in childhood, especially, you know, those young, lovely young kids going through puberty. Okay, it affects the pilosebaceous unit. It can bother males, females, and all ethnic groups. If it goes past the time for infantile, so sometimes we'll see it in infantile, right, with the little milia and stuff on the nose. Or adolescent, it may be caused by endocrine abnormalities. It also can occur in response to certain drugs, steroids, androgens, dilantin, and others. So for acne neonatorium, this is a response of maternal androgens to the newborn. All right, so it can happen right after birth or within 2 to 4 weeks. And there's usually no treatment necessary. But if it is severe and there's a risk for scarring, they may give it a topical application. You wouldn't want anybody to pick or squeeze the pimples, okay, because that can put them at risk. And you also don't want to use fragrance, soaps, or lotions over the area. Once the newborn's hormones start to stabilize out, usually it will start to resolve. With the acne vulgaris, this can begin as young as 7, but usually occurs in the ages of 12 to 16. It's caused by the endogenous androgens. So endogenous means ones that re-release inside our body. All right, it occurs more frequently in the face, the chest, and the back. And it can happen in pre-adolescence, adolescence, and more often in the male gender. And it's due to this oily complexion. Cushing's syndrome, where we produce a lot of fat and a lot of fat pads, and we have an increase in that androgen production, could also cause it to be worse or more at risk. So here we have these sebaceous glands that produce sebum. They're connected to the ducts at the skin's surface. The androgens stimulate the sebaceous glands to produce sebum. And the hormones increase activity during puberty. So we have this abnormal shedding of the outer layer of the skin around that follicular opening. And this causes the keratin to plug the follicle. And the sebaceous glands will increase the production. We'll get overgrowth of bacteria, and that causes the presence of sebum and keratin in the follicular canal, which allows for that bacteria to grow. So as it does grow, we see inflammation, and the follicular wall will perforate, and that allows the contents to leak out into other tissue nearby. So we want these kids to gently cleanse the skin twice a day. They might need things like benzoyl peroxide, salicylic acid, retinoids, topical or oral antibiotics. If they are severe, they could use something called isotretinoin. In girls, oral contraceptives can sometimes help to lessen the acne by decreasing the effects of the androgens. And also they may use laser or ultraviolet light therapy, carbon dioxide lasers, or derma abrasion to prevent scarring or pits. Chocolate milk, skim milk, and French fries have not been proven to contribute to the incidence or severity of acne. However, teens should wash their hands after eating any greasy foods to avoid spreading additional oil to the surface of the face. These are your signs, mild acne, moderate acne, and severe acne. So following statement, true or false? The nurse is assessing a child for acne vulgaris and notes comedones plus papules localized on the face. This is classified as mild acne.
Severe.
So mild acne is primary
Oh.
non-inflammatory lesions or comedones. Moderate acne is comedones plus inflammatory lesions such as papules or pustules and is localized to the face or the back. And then severe acne is lesions similar to moderate acne, but more widespread, more cysts and nodules, and more scarring. So that's false. Okay?
Moderate. Yeah.
False. Comedones plus papules localized on the face is moderate. All right, burns are a preventable injury among kids and adults. Youngest children are at highest risk for burns, and mortality rate from burns is higher in children that are under 5. Most pediatric burn injuries don't result in death, but they do cause extreme pain and extensive burns, and they can also result in serious disfigurement. Fires in the home are often related to cooking, cigarette, or other smoking material, and carbon monoxide poisoning often occurs in conjunction with the burn as a result of smoke inhalation, and infants and children are at greater risk for carbon monoxide poisoning than a grown-up. So classifications of burns: partial thickness burns greater than 10% of the these are burns that would require admission to a special burn unit. Okay. I guess we should talk about these first, the criteria. So the superficial burn is going to be in the epidermis area only. If it's partial thickness, it would involve the epidermis and also spread to portions of the dermis. If it was deep partial thickness, it's going to extend deeper into the dermis, and full thickness extends through the dermis, and the hypodermis. So if the child has a burn greater than 10% of this total body area, a burn that involves the face, the hands, the feet, the genital, the perineum, or the major joints, a full thickness burn of any size, a chemical or electrical burn, because we can't measure sometimes how deep those go. Inhalation burns, a pre-existing condition that might affect care, a burn along with traumatic injuries, or they require some sort of special social emotional support. If they're in a hospital that doesn't have qualified burn personnel or equipment, all right, they would go to a specialized burn unit. All right, so superficial burns involve only epidermal injury, and they usually heal without scarring within 4 to 5 days. In partial thickness, the injury occurs not only to the epidermis, but to part of the dermis. And it takes about 2 weeks to heal with a minimal risk for scarring. Deep partial thickness burns would take longer to heal. They can scar. They can result in changes to both the nail and the hair beds, as well as the sebaceous glands. They also require some sort of surgical intervention. And then full thickness burns will have significant tissue damage. They'll go through the dermis, the epidermis, and the hypodermis. You'll have extensive scarring. the hair follicles and the sweat glands are destroyed. These require a large amount of time to heal. And if the tendons or the bone that underlie the burn are involved, it could be termed fourth degree. Contractions and limited function can occur with full thickness burns. Skin grafting is usually necessary, and full or partially circumferential burns can cause ischemia from a loss of blood flow related to swelling in that area. Due to overlying blistering, it's sometimes difficult to accurately distinguish between partial and full thickness burns. In addition, third degree burns, it's difficult to estimate the burn depth during the initial evaluation. If the child does experience carbon monoxide poisoning, all right, they may find high levels of carboxyhemoglobin from smoke inhalation, and that could cause them to have false pulse ox readings. So wet dressings, these are usually dressings that are wet underneath the surface. And then they go towards usually a dry dressing. Trying to see if I could see these in your book somewhere because they're not just popping up where they should be. These can sometimes help hydrate the wound and promote tissue granulation of the tissues. So not having much luck with finding them. Your book does talk about cleansing the wound, so we'll just talk a little bit about that. All right, so initially you want to stop the burn. All right, so if they have charred clothing, you're going to remove it. You'll wash and rinse the burn with mild soap and cool water. Do not apply ice. All right, children that are burned with tar require special care. So you'll remove the tar with cool water and mineral oil. You don't routinely remove blisters because they can help provide a protective barrier, but debridement may be recommended in certain cases if large blisters somehow impede the wound. If the wound is open, it would probably require debridement, and that is removing the loose skin and that dead or eschar, what we call dead or charred tissue. That would be done with sterile scissors, forceps, and a gauze sponge. We would cleanse the wound. There's no advantage to aggressively scrubbing it, and it can make it only more painful. Wear a gown, mask, and head covering and gloves during the dressing changes. Debridement is necessary, but often excruciatingly painful, so we need to make sure that we're managing the pain appropriately. If you're removing the dressing, you want to soak it with lukewarm tap water to ease the removal of the gauze because it could be stuck to the wound. Make sure you have all your dressing supplies on hand, that you've given the pain medication, that you're using good infection control techniques. If you have to help with the child with positioning and stuff, that you do so. Encourage participation by the parents, and talk soothingly to the child and let them know what you're doing, and provide distraction during the procedure. Common medications, okay, are going to be antibiotics. These can be for any type of prevention, infection, or prophylactic. Okay, so we have the infection and we're trying to stop it, or we're going to give it prophylactically to prevent the infection from occurring. Steroids, these are going to help with inflammation. Antifungals will help with any sort of fungal infection. They can be topical, or we can give them systematically. Topical immune dilators, these are usually used for severe atopic dermatitis. And those are to try to decrease that immune response in the body. Antihistamines, again, for the same thing, to reduce that histamine response in the body. The isotretinoin, you should know about this when they ask about this a lot. This is usually used for severe acne. And so you want to know a couple things about vitamin A, about birth control, all that when you're prescribing this medication. Coal tar preparations used for psoriasis and atopic dermatitis, and then silver sulfadiazine. This is used for burns mostly. This nurse is caring for a child with severe atopic dermatitis. Which of the following medications would be recommended for this condition? So let's eliminate choices here, okay? C is for burns. A is going to be for acne.
Acne.
So now you're down to B and D.
I think it's D. Oh. Can it be D?
It's actually B.
D?
The immune, remember that the atopic dermatitis has some autoimmune properties to it. So the immune dilators, modulators. All right, retinoids for the acne, silver sulfadiazine for the burns, and systemic corticosteroids for the dermatitis, for the contact dermatitis. For urticaria, remember this is the hives, right? So we're looking at anything that the person might have been exposed to that was different. Not that you can't develop a reaction to anything anytime you're taking it, because you can, but typically the first thing we look for is exposure to new things. So new foods, new medications, some sort of recent infection, some sort of change in the environment, or stress. Remember, the hives can last for a couple of hours or for a few days. All right, we're looking at the skin for those wheals, or those raised edematous hives. They're called wheals, WHEALS. All right, and then also with this, because it's an allergic reaction, we also have to make sure that we're looking at the airway and the breathing. Causes: allergies to foods, allergies to drugs, animal stings like those bee stings, infections, environmental stimuli, and stress. For kids, okay, for burns, we need to promote hydration, right? Why?
Because they lost water. With burn, you get dehydrated because you lost.
The skin's open, the integumentary is impaired, and they're losing fluids from the skin. Okay, and also the cells are disrupted. So these patients are at risk for tissue destruction hyperkalemia, things like that.
Infection.
All right, so we're going to promote oxygenation and ventilation, especially if they have those upper airway or facial injuries. Hypothermia, because again, the skin is impaired, so the body is not able to regulate the way it's normally able to regulate the temperature. We have to make sure we're using sterile technique when we're cleansing those burns. All right, and that we're not hovering over the burns without a mask and talking over them, because we have bacteria and stuff coming out of our mouth. So when you're cleansing these areas of the body, you want to make sure that you have appropriate PPE on. You're preventing infections. Remember that you're going to have to give care to these wounds that are extremely painful. So, and that's really going to depend on the degree of the burn, because sometimes if it's a full surface burn, a full body surface, they may not have pain because the tissues and stuff are destroyed. But if it's partial, then they may be more painful and they maybe need medication before you do the treatment. And then burn rehab. Remember, sometimes these burns can encompass the entire arm and the legs. So we have to watch also for compartment syndrome with these patients, circulation impairment, okay? Because sometimes we have to do like escharotomies and stuff like that, because the skin will pull so tight that it actually impairs the circulation. For management of the diaper dermatitis, we're changing those diapers frequently. We're avoiding things like rubber pants. I don't even think they make those anymore. Does anybody know what rubber pants are?
No, I don't.
So when I was a kid, we had cloth diapers. And so the also would sell these things that called rubber pants. And they were made out of rubber. And your mom would put them over your cloth diaper, so when you peed in the cloth diaper, it didn't go through all your clothes and stuff. Now everybody has disposable diapers, and the disposable diapers prevent all that, so they don't use the rubber pants much anymore. But sometimes you might see them on either really poor kids, because their moms might opt to use the cloth diapers because they're definitely a lot cheaper than the Pampers. I never use Pampers on my kids. I always use cloth diapers.
Because you wash them, right? You wash them and
Yeah, we
reuse
wash
them?
the diapers and reuse them. Yeah, and we used to have a diaper bucket that you would put the diapers in and you would soak them. It would usually have some sort of solution in them, bleach and laundry detergent, and we would soak the diapers in there. This was what being a mother was like 50 years ago. You would take the diaper and we would dunk it in the toilet to get the poop off. So you would dunk it in the clean toilet to get the poop off, and then you would stick it in the diaper bucket and it would soak in there, and then a couple of days a week or whatever, you would wash the diapers. So you might still see these also on kids that come from a really elite sort of family, because a lot of times the rubber pants now that they make, the ones that they make now, are fancy. So they're not really made out of rubber so much. They're like this synthetic stuff, and then they'll have like frills on them, like little ruffles and all that stuff. So if you notice, sometimes when you buy a fancy dress for little girls, they'll have those little rubber pants attached with them that have the little frills and stuff on them. Baby wipes with any sort of fragrance or preservative, any harsh soaps. Okay. And then once they get the rash, remember, no powder. Okay. The powder has to do more with inhaling it. All right. Letting the child go diaperless. So, I mean, this is big. We did this for years. Put the kid out back in the sunlight. Okay. Cover their head so their face don't get sunburned and all. And let their booty hang out in the fresh air in the sun. That's really what A&D ointment is all about. It's bringing that sunlight to the chemical. Bring those vitamins that you would get from the sunlight to the chemical. All right, so you're not going to put the kid out in 98-degree weather, okay? So you have to use your brain here, because you don't want to give them a sunburn on their cooch. But you can dry out the diaper area and stuff if you do this appropriately. And then using a blow dryer with the setting on warm, not hot, for 3 to 5 minutes just to dry the area out. animal bites prevention. Okay, this is something really that you really have to talk to your kids about. Okay, if you have a dog in the house, all right, because little kids don't understand with dogs. Like, you don't put your face in the dog's face ever. You don't put your face in the dog's face, and you don't touch the dog when it's eating ever. And then you got to be careful, by provoking the dog with teasing, roughhousing. Make sure that you're getting permission before you interact with somebody else's dog or touch it, because the dog may not be used to that person. Okay. And then not bothering someone who's eating, a dog who's eating or sleeping or nursing. Certain noises around dogs can set them off, high-pitched noises, firecrackers, those kind of things. All right. And then be mean towards the dog. So you want to keep, be nice to the animals, teach the kids to be nice to the animals, because some of them are very abusive and they pull on the animals. And if you're getting animals from the shelter, you want to make sure that they have some sort of documentation that that animal is okay to be around kids. Because if it's been around kids that previously abused it, there could be issues there. All right, so the last chapter, you guys are going to have to hit it on your own. All right, for skin.
I think it's infection. Infection, we just explained.
But if you guys want to go through a couple skin questions real quick, I'll do that with you.
Oh. Okay.
Let me know when you can see it.
Yes.
Okay. So the nurse is monitoring a child with burns during the treatment. Which assessment provides the most accurate guide to determine the adequacy of fluid resuscitation?
I'll be looking for hydration, right? Skin
Yes.
turgor? That would be skin turgor?
I think it's 3.
Oh.
It's good. We're learning here.
Let me refill.
Okay, parameters such as vital signs, especially heart rate, urinary output, volume, adequacy of cap refill, and state of sensorium determine adequacy of fluid resuscitation. 1, 2, and 4 can provide some information about fluid volume in a burn injury. However, adequacy of cap refill is more accurate. The mother of a 3-year-old arrives at the clinic and tells the nurse the child has been scratching the skin continuously and developed a rash. The nurse assesses the child and suspects the presence of scabies. The nurse bases the suspicion on which finding noted on assessment of the child's skin. Scabies. So we talked about 3. What is 3?
It's
Impetigo. Impetigo.
Yeah.
Okay, impetigo.
I think it's 1.
I think it's 1. Yeah.
Okay, I like 1. I like 1. 4, I would associate more with like chicken pox or something like that. Not sure what 2 is, but I like 1. All right, so scabies for the red-like lines. Purple-colored dyslesions are systemic conditions. Okay, so that's why we couldn't figure it out, because it's not really for anything particular. I kind of was thinking along the lines of like petechiae or purpura when I saw that, so I was thinking bleeding. 3 for impetigo, and 4 actually herpes virus. All right, I said chickenpox, so I guess that would fall along the same kind of lines, but maybe not. All right, permethrin, what do we use this for?
For scabies,
Yeah, and there's another one we use for scabies too.
the scab, it's scab. Well, it's the same name, but it's just same name as the scabies, but it's scabies something.
Okay, so you have to watch these in some kids, okay, because there's 2 different ones, and one of them can lower the seizure threshold. All right, so you have to watch it with seizure patients. All right, so how would we apply this?
I know you would leave it for
So the dry skin.
So is 1 true?
We don't
no,
apply
you apply
the
it
rash.
to the
Yeah.
whole body though, right?
Okay, true. How long do we leave it on usually?
I think it's 8 to
More than 8 hours.
It says 8
Usually
to
around
14
8
hours.
to 12 hours. Okay, is 3 true?
By putting clothes on the child.
No, no.
Okay, so then I would say 4 is the answer here.
All right.
Just eliminating by choice.
Lotion to cool dry skin.
Okay, it goes from the head to the soles. Okay, we just have to be careful around the eyes.
Yeah.
We're going to give a bath and then apply it about 30 minutes after the bath, okay, to the cool, dry skin. Leave it on for 8 to 14 hours, this says. We usually leave it on for 12. All right, and then we're going to wash it off. And they can't wear clothes. Otherwise, we'd have a bunch of people running around naked. School nurses provided instructions about impetigo to the parents of a children attending the school. Which statement, if made by the parent, indicates a need for further teaching?
Further teaching them is which one is not true. 1 is true, that is contagious. 2, yes, it is mostly in hot weather. Release and most often are located in the arms and chest. I don't think so.
Don't you see it in the face though?
The mouth and the nose, right?
Yeah. So
this.
3 is not.
3
4
is
is
not
true,
right.
right? It's going to happen from an area of skin that was broken, and then the bacteria got in there and caused this infection. Sweating makes it worse. Okay.
So it's 3 because you see it in the face. I mean, that's so hard.
Okay, so contagious, caused by that B hemolytic strep or staph or both, most common in hot, humid weather, caused by that area of broken skin like an insect bite or atopic dermatitis, and around the nose and the mouth, honey crusted lesions. The clinic nurse is reviewing the primary healthcare provider's prescription for a child. There you go, Lindane, who's been diagnosed with scabies. Lindane has been prescribed for the child. The nurse questions the prescription for which, if it's noted in the child's record.
4. I think it's 1.
It's 2
So
years old. Yeah.
you don't give it till 2 years, right?
Yeah.
Oh, 1.
I think so. I think so.
Okay, Lindane is used to prescribe to treat scabies. It's contraindicated in kids under 2 because remember we talked about the thin skin and how some items can be more toxic. All right, high absorption can occur. Also, remember I talked about the seizures?
Yeah.
Okay, it lowers the threshold. This is the one. Also used in caution with kids between the ages of 2 and 10, and then the other options weren't really applicable here. Topical corticosteroid is prescribed for a primary healthcare provider for a child with contact dermatitis. Which instructions should the nurse give the parent about applying the cream? So how are we going to apply this steroid cream?
No, 1 is not true. Apply a thick layer of cream to affect affected area. It's not thick. It's then avoid cleaning the area before application of the cream.
It's 4.
Maybe 4, yeah.
It's
But
4 because you apply a thin layer, you don't apply a thick layer over the whatever.
Okay, good. All right, so contact dermatitis is a superficial inflammatory process involving the epidermis. The corticosteroid may be prescribed and applied sparingly as a thin layer and rubbed into the area thoroughly. The affected area should be cleaned gently before the application. Systemic absorption is more likely to occur with extensive application. So we don't put it over large areas most of the time. School nurse is performing pediculus capitis, head lice assessments. So capitis, remember the cap of the head, right? It's going to be involving the scalp. Which assessment findings indicate that a child has a positive head check for lice? So we already said that one is flat red lesions, right? So we can eliminate that.
It's 4?
Okay, it probably is 4. Let's go through the other ones. Lesions in the scalp that extend to the hairline or the neck. I would say that could be possibly some sort of scabies or something. White flaky particles, I would say dandruff, right?
Mm-hmm.
So I like the white sacks because that lice, it looks like a little white sack, right?
Yeah, it looks
the
like
hair
the
shaft.
eggs.
And
The
the-
eggs looks like.
Nurses caring for a child who sustained a burn injury plans care based on which pediatric considerations associated with this injury.
Burn injury.
One is natural. Foreign is they're more susceptible.
3.
So 2, I think true. A delay in growth may occur after burn injury. Fluid resuscitation is necessary unless the burn area is more than 24% total body surface. I would say it's necessary. 4 is not true. So the lower proportion of body fluid to body mass in the child increase the risk of lower proportion. They don't have a lower proportion of body fluid too. No, they have a higher. How about 6? Infant and young children are at risk for protein and color deficit because they have a smaller muscle mass and body, less body fat than adults. Yeah, I think 6 is also true.
Okay, so scarring is more severe in a child than an adult. A delay in growth may occur after a burn. The immature immune system presents an increased risk for infection. The higher proportion of body fluid to body mass in a child increases the risk of cardiovascular problems. Remember, they have a high body weight, 90% of fluid. Burns involving more than 10% of the body surface area require fluid resuscitation. Infants and children are at increased risk for protein and calorie deficiencies because they have smaller muscle mass and less body fat. All right, so us also, okay, we would use fluid calculation based on the body surface area burned. We would use a crystalloid solution like lactated ringers in the first 24 hours. And in smaller kids, we may add dextrose. We would administer most of the volume in the first 8 hours. And then resuscitation would vary from child to child. We would reassess the child and adjust the fluid rate accordingly after 24 hours if it needs to be decreased. We would administer the colloid fluid later in the therapy once the capillary permeability is less of a concern. And colloids are going to be more like, blood or albumin, stuff like that. We'll monitor the urine output as part of the ongoing assessment in response to therapy, and we would expect at least 1 milliliter of fluid output per kilogram per hour. We would monitor daily weights at the same time each day. That's our best indicator of fluid volume status. And we would monitor the electrolyte levels, especially the sodium and potassium, looking for a return to the normal level. The nurse is monitoring a child with burns during treatment for burn shock. Which assessment provides the most accurate guide to determine the adequacy of fluid resuscitation? So we did this, but that's okay.
Yeah.
Hopefully
We
the
did say
ones that
3.
didn't get it the first time, remember this now.
It was me.
So
That's important.
also you're looking at, remember, we're looking at the urine output. We're measuring that, and we're looking at daily weights.
Mhm. What does it mean?
They're bringing us the same questions.
Yeah.
All right, let's see if I got some more in this other slide over here. I guess we have to go with all. Well, it's only 8 here. We'll go through those. And I think we went through all the neuro ones, but we'll pick that anyway. We'll skip anything we didn't go through. And then we're going to call it quits. Okay. The nurse is reviewing teaching with the parents of a child who has tinea capitis or ringworm of the scalp. It's newly prescribed glycylfulvin oral suspension and 1% selenium sulfide shampoo. Which statement by the child's parent requires a nurse to intervene? So we're just learning here. You guys may or may not know this medication.
Sulfur shampoo, stop it.
One?
How about
In,
one?
is it
Yeah,
one? I'm not sure though. I'm just.
Okay.
because she
We're
should
gonna learn.
finish it.
We're gonna learn, right?
Yeah.
And you got it right. All right, so we have this fungal infection on the scalp. It's going to be scaly, pruritic, edematous. We're going to have circular patches or that annular ring. Okay, it's infected. It's transmitted through direct contact with any person, pet, or object. Also, hairbrushes, bedding, wet towels. So we're treating it with the selenium shampoo several times a week and the antifungal medication, which is that glycylfulvin. All right, which the client would take for several weeks to months. To ensure that the infected keratin is shed completely, the treatment should not be discontinued early, even if symptoms decrease. All right, so good job on that. Parent, what happened? Oh, it went to YouTube for some reason. Where was I at? parent of a 6-year-old calls the nurse and reports the child was playing outside in the snow and the child's feet now appear red and swollen. All right, so what's happening with the child?
Nasal,
Infection.
and it's red, so it's not, it's nasal.
Some sort of frostbite, right?
Mhm.
Yeah.
They're in the snow. What's the best response by the nurse? So how you gonna warm these toes up without harming them? That's what it's asking you, really.
Keep it in a warm
Can you do
water.
warm water?
Okay, so for cold injuries, rewarm, okay, in warm water for about 30 minutes or until the area returns pink. All right, we don't massage because that could cause more tissue injury. A nurse is teaching the parent of an 8-month-old infant about a baby who had a febrile, a nurse is teaching the parent of an 8-month-old infant who had a febrile seizure about management of future fevers, which we did this one.
Yeah.
We're giving Tylenol, right? We want to keep the fever down.
Yeah.
That also.
This one, but I'm
did
gonna
that.
do it again.
We did
I'll do
that
it again
too.
since we just went over this. So what are my answer choices here for atopic dermatitis?
1,
3,
3,
4.
Good. And just so anybody doesn't remember, I'm going to just go over this, okay? It's known as eczema. Remember, it's associated with things like asthma, chronic skin disorder, characterized by that pruritus or that itching, that erythema or that redness, and that dry, scaly skin, as you'll see with those plaques, right, all over the skin. Associated with impaired skin barrier and an immune response to different allergens. Primary goals to stop the itching because the itching can cause them psychological issues and drive them crazy. Keep the skin hydrated. You're going to give tepid baths, okay? Emollients that help seal the moisture in the skin. Remember, Vaseline is a cheap one that could help them out, okay? No hot water, tepid baths, drying and patting instead of rubbing, short nails to prevent infection, soft cotton clothing, and clothes that are non-allergenic. Child's arm is burned from accidentally spilling boiling water on it. The parent calls the clinic. The nearest emergency department is an hour away. Which instructions would be appropriate to give the parent?
Cool water. Move the clothing if not stuck to remove the burn. Cover the area with
would they
clean.
have I think 1 is
We can't apply it at open.
Okay, so here you go. Run cool water over the area. Do not apply ice. Do not apply butter, ointment, or cream.
Yeah,
Cover the
we're
burn
not-
lightly with
we're
the.
not, we don't see it. You press submit it already? Because we don't see the answers.
No, I didn't press submit. I'm just going
Oh,
through the article.
oh, okay.
And then I'm going to read the one from here. All right. Just so
Okay.
you get it, just so it sticks. All right. Cover the burn lightly with the clean cloth. If it's a first degree burn, you can give something like acetaminophen or ibuprofen. You're going to send them to the physician. Okay. If it's a more extensive burn, you can remove the clothing if it comes off easier, or if it's still smoldering, check for the airway, breathing, and circulation. Avoid applying like large wet sheets. Okay. Do not break any blisters. And if the client appears to be in shock, elevate the legs while protecting the burn and call 911. All right, let's look at these ones. Good job. All right, so proper emergency care can prevent infection, prevent hypothermia, and prevent further tissue damage. So we want to contain that burn. Soak the area in cool water to stop the burning. Remove any clothing around the burn or jewelry to avoid constriction. Don't remove anything that's stuck to the burn. Cover with the clean, dry cloth to prevent contamination, trauma, and hypothermia. Do not apply medications until prescribed by a physician. Do not place ice or ointments on the burn. All right, good job. Nurse is caring for a 3-month-old who has bacterial meningitis. Which clinical findings support this diagnosis? So let's look at one. How's our fontanelle going to be more likely?
Bulging.
Okay, good. Are they subjected to seizures?
Yes.
Yes.
Are they going to have a high-pitched cry?
Yes.
Because if they have ICP, they'll have that, right?
Yeah.
Would they have poor feeding?
Yes.
Yes.
Would they have a Babinski sign?
No.
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 Kernig or Brodzinski, right?
Yeah. Kernig and Brzezinski. And vomiting, yes.
Yes.
Great job. All right, inflammation of the meninges and the spinal cord caused by bacteria, strep B, meningococcal or pneumococcal pathogens, fever, hypothermia, irritability, seizures, high-pitched cry, poor feeding, vomiting, nuchal rigidity, bulging fontanelle, hydrocephalus. So we're measuring that head circumference, right?
Yes.
Nurse performs assessments on 4 infants. The nurse should alert the healthcare provider to see which client first. Okay, let's look at 4. What is 4? What are we doing there?
Babinski.
That's
Babinski.
Babinski.
Okay, we're doing
That's
Babinski,
expecting.
and our child is under a year old. So do we like it or not?
Yes.
Yes.
Okay, great. Number 3, how many wet diapers do we expect the child to have throughout the day?
6 to
6
8.
to 10. 6 to
Okay,
10.
That's normal.
6 to 8, 8 to 10, depending on the age. Okay, this is 6 months old. I'd probably say more like 8 to 10. And vomited twice. I'm a little concerned, but it may not be my first client to see. All right, how about number 2, sunset eyes?
It's ICP.
Okay,
Yeah.
and number 3 is a posterior occiput appears flattened. What would that be from?
That's
Dehydration.
expected.
Hydration.
So we're talking
that's
about
expected.
the occiput area. If we're talking about the occiput area, it's
Oh,
probably
okay.
like that flat head that the baby gets from laying in one position all the time. That's what I'm thinking.
You just
Right,
have to
so-
turn the baby.
Yeah, so I'm probably thinking 2 here, right? There you
Yeah.
go. See what
Oh.
I told you, you'll notice it right
Oh.
away.
Yeah.
Unforgettable once you see it.
Mm-hmm.
And the scalp veins, because the head is tight, it's full of fluid. And remember that the veins are real close to the top of the head. So they're going to become more prominent as that head fills up with fluid. All right, so we're going to see hydrocephalus, increased ICP. That's caused by that obstruction of that cerebral spinal fluid, okay? And that's going to cause brain damage and death if we don't fix it. The baby's going to have bulging fontanelles, an increase in the head circumference, and those sunset eyes. Okay, and that sunset eyes occurs, remember we talked about that aqueductal structure being blocked? That fluid
Yeah.
can't get out, and that's what's causing those sunset eyes.
Doesn't
Right.
feel-
Also, with these babies, what else are you going to see, or with anybody with increased cranial pressure, is that Cushing's triad. So the wide impulse pressure, the bradycardia,
Bradycardia,
and what else?
bradycardia, white pulse, and respiration. What is it? No. Oh God, I forgot the last one.
Pulse and
Is it rest? That's not respiration, right? White pulse, bradycardia, and I forgot the last
also
one.
respiratory
What's
depression.
the respirations?
Respiratory.
Okay, you were
Yeah.
right.
Well, I did say respiration.
It was. You were right. All right. I was just letting you think on it. I was trying to get some of your friends to pitch in and help. Okay. So number 1 was the flathead syndrome. Okay. Number 3. All right. We're looking at the 6 to 10 diapers. So that's how we eliminate that. 4, knowing that Babinski reflex should be normal in a baby up to a year old. That would help us eliminate that. So really, it's not picking the right answers. Remember, we're going to eliminate those horrible choices so you can get to the best answer. Okay.
Miss Sue, can I see that picture again of that baby, the head of the baby, please?
Let me make this a little smaller so you can see it a little better.
Okay. Okay. Oh wait. Down a little. Put it. Okay. All right. There. That's it. Thank you.
You're welcome. All right, the emergency department triage nurse is assessing 4 pediatric clients. Which client is a priority for further diagnostic workup and definitive care?
1, we
That's
did that already.
One, yeah,
Yep.
infection.
Sorry, sometimes I don't recognize them right away,
That's okay.
but that's all right. We're learning, right? Remember with these
Yeah.
shots, they're used to treat hydrocephalus, usually put in around 3 to 4 months. Common complications with them are blockage and infection. And then
that's
we're going to
pressure.
see that increased cranial pressure. We'll see that Cushing's triad with the bradycardia, the slow respiration, the wide impulse pressure, the meningocele. Remember, that's that sac in the back. We don't want to rupture that sac. So we put the client face down with the head to the side, right? We're going to put sterile dressing on that sac to help protect it. Okay. And then the other one was talking about muscular dystrophy. Nurse is preparing. Oh, we did this one. We'll go on because seizures you guys should kind of have down. When performing developmental screens in the Well Child Clinic, the registered nurse understands that which child is at highest risk of developing autism.
Years old who has a vocabulary word of 10. 3-year-old who receives measles, mumps, rubella, wax, immunization at age of 1.
4.
About 3, 4 years old whose 10 years old sibling has a disorder.
So 5, I would associate more with Down syndrome. 4, I would associate more with Down syndrome.
Oh, Down syndrome.
3, the genetic is probably going to be your answer here. I don't see anything else. So actually for 4, it says that they're in the process of doing studies, but so far they haven't been able to associate older age with autism. We did this one.
Yeah, it was 1.
Yep, you know you got to bite that infection, but you're also going to do other things, right? You're going to keep that head of the bed at a 15 to 30 degree angle. You do want to make sure that they have low stimulation. We are going to put seizure precautions in place. We are going to monitor that head circumference, okay, for ICP. The nurse taught the caregiver of a child with a ventricular peritoneal shunt about when to contact the healthcare provider. The caregiver shows an understanding of instructions by contacting the physician about which symptom.
Is it 3?
Temperature of 99. Child cannot regulate.
Yeah, I like 3 of
Can
the,
it be 3? Because like if it's not working, so
I do like
About
3 of the choices.
Indian LOC. Okay. I think
Okay, good job. So there's your shunt there. All right.
Yeah.
The caregiver of the shunt must understand about the symptoms of increased cranial pressure, which indicate that the shunt is not working. Vomiting can be a sign of increased pressure and would indicate that the physician needs to be contacted. Fever would indicate shunt infection, but 99 is acceptable. Memory lapse or changes in mental status may indicate increased cranial pressure, but inability to remember a meal is not an indication of mental status change. A VP shunt is tunneled under the scalp and can be palpated. So that's normal. So it's good to know that that's normal. So now you know if you see this again, that would be a normal finding. The nurse is caring for an infant with suspected meningitis and preparing to assist with the lumbar puncture. What is the appropriate nursing intervention?
these are clinical.
is it 3?
Yes. Remember I said
Because you hold, yeah, you
chin
hold them.
position, because we need to go in that subarachnoid space and we don't want this child to get harmed.
Yeah.
We don't usually give oxygen, so that wouldn't be a thing. If we were going to give something, it would be that Emila cream, or if the child were extremely fearful, we might have to give some sort of sedation.
Mm-hmm.
The other ones are nursing interventions that we might use. I would say for 2, I probably would use chlorhexidine unless the child was allergic to it. And I don't know about how often we have to monitor the vital signs. So optimal position is head and knees tucked, back rounded out. That provides room. Okay, unless the client has some issue where they're already getting oxygen, we wouldn't be giving that. Unless the client is unstable, no need for vital signs every 15 minutes. All right, community health nurse is planning education for adolescents about skin care for acne vulgaris. Which of the following points are appropriate to include?
1.
2.
2.
4.
4. 5.
5.
Good, great job. Okay, so characterized by obstructed sebaceous glands, forms those comedones, which are blackheads and whiteheads. That's all they are. All right. Bacteria consume and metabolize the obstructed sebum, and the metabolic products cause inflammation, pustules, papules, and nodules. Usually develops in puberty. Multiple factors influence the development of it. Maintain a healthy lifestyle. Avoid antibacterial soaps. refrain from squeezing or picking, use non-comedogenic projects, so products that don't block the pores and create those blackheads and whiteheads, gently cleanse the skin. And then you want to know about that isotretinoin if they do prescribe it, okay? The clinic nurse is reviewing, I'm sorry?
No, I said yes.
The clinic nurse is reviewing self-care management of acne vulgaris in an adolescent client, which statement requires a need for further teaching. We did this one, right?
1.
We did this one. Impetigo, right? We did this one.
Yeah.
Okay. 7-month-old is admitted to the unit with bacterial meningitis, suspected bacterial meningitis after receiving an initial dose of antibiotics in the ER. Frequent assessment of the following is most important in the plan of care. I think we did this one.
Yeah.
2.
It was functional assessment.
Okay, that would be early signs of ICP, and then the pulse pressure, we would look for later signs, right?
Yes, the
Bradycardia
portion thing. Unless that what is the body
I don't think we did this one.
No.
No.
Okay, so priority when caring for a 6-month-old diagnosed with atopic dermatitis.
Prevent scratching.
Yeah, because it can cause
Yeah.
infection. It's 4.
Okay, good. All right, prevent that scratching to prevent the infection. We're not going to use a humidifier. Well, it does say you can. The reason why I would have said no, I guess if it's cool air, it'd probably be okay. Just because they were talking about the humidity and all, but I guess the humidifier would be okay. All right, caring for an 8-year-old, we did this one.
Mm-hmm.
Oh, that's it. This is the last one.
Schedule about EEG.
Scheduled for elect EEG, which statement by the parent indicate understanding of teaching. I will let my child drink cocoa
I think it's
as
2.
you learn. I will wash
2.
dish. Yeah, I agree.
2.
Yeah.
Yeah.
All right, good job. All right,
Oh,
so
is it to take
hair
the
is
grease
washed,
off?
remove the oils, okay, so that they
Yeah.
can stick better. And then we
Mhm.
would avoid any kind of stimulants.
Yeah.
And it's not painful. They'll be awake during the procedure. We don't
Yeah.
use sedation because it would affect the brain waves. All right, guys, this will take a little while to record so I can put it on YouTube. Good luck on the test.